Alright guys, can you all hear me? Can you all see me? Quick feedback. Good evening guys, good evening. Can you all see me? Can you all hear me? Quick feedback. Alright guys, can you all hear me? Can you all see me? Alright, so the exam is just around the corner and we know you're a little bit tense and worried, so we thought why not practice few questions which are going to be high yield. Hello, good evening guys, good evening, good evening, good evening, good evening. ठीक है, I am great, thank you for asking. I hope you all guys are doing well. You know, okay, I don't want you to panic, I don't want you to overburden yourself. We'll try to focus one question at a time and we'll try to decode one question at a time. Okay, let's keep the discussion very crisp. Voice is a little bit slow. Beta, voice आपको बढ़ानी पड़ेगी. मेरे end से the voice is full below. है ना? Yeah, I've got a full throttle of the voice, so yeah, pretty much sure. चलो. Okay, beta अभी थकना नहीं है. ठीक है, right now it is not the time for you to hold back. This is the time to give it all, right? अब आगे I don't know who is telling you about the preparatory exams. एक basic rule है, you have to give 18 hours a day. There is no if, there is no but. If people are telling you to sleep for 8 hours, eat for 4 hours and have a recreation and then read, that is not going to work in our exam or any competitive exam. 18 hours per day is to be given, और अभी से exam तक every single day and night you have to dedicate for your exam. This is the time for revision. ठीक है, चलो. Most of the PYTs and PYQs will try to cover here. One question at a time. ठीक है, let's start with the question number 1. So this is the question number 1 that we have. Now in question number 1, this is again a previous exam question only. I want you to just focus a little bit. A patient admitted in the surgery ward. A patient is admitted in the surgery ward, is undergoing a bariatric surgery, right? The patient is undergoing a bariatric surgery for morbid obesity in the upcoming week. He'll be managed as per IRAS. Now, this is very important. What is IRAS? It is your enhanced recovery after surgery. That's the protocol that we follow. Which of the following statement below is false regarding the protocol? Now, IRAS is a protocol which tells you that how do you manage your patients, that is pre-operatively, intraoperatively, and post-operatively, to get a best adequate outcome. The point number 1 is discharge planning is started before the patient is even admitted. Absolutely correct. We will anticipate and then we'll actually make the plan for discharge. It can be used for colorectal surgeries. Yes, it is in fact started for colorectal surgeries. This is also true. Adequate pain control. There is no if, there is no but. This has to be done. Waiting for a week to start oral feeds. Why? Oral feeds should be started as early as possible. In fact, I'll start after 4 hours of surgery. So which is false? It is D for Delhi is false, right? Okay. Now, IRAS protocol is this. We say it is a nutrition protocol, that is an enhanced recovery after surgery. Now, we have a pre-operative and post-operative. In pre-operative, we screen all the patients for malnutrition and always do an adequate nutritional support. Then you have to decrease the fasting period. Earlier, we used to say 12 hours of fasting, 8 hours of fasting. No. For solids, remember, it is 6 hours. And for clear liquids, it is 2 hours. For solids, it is going to be 6 hours, and for clear liquids it is going to be 2 hours, right? And we also do carbohydrate loading, that is so that the patient has an adequate amount of reserves even after the surgery, and that is going to be 100 grams prior to the surgery in the evening and 50 grams up till 2 hours of pre-anesthesia, right? 50 grams of carbohydrate can be loaded at least 2 hours prior to the anesthesia. This is your pre-operative. Post-operative will maintain the glucose control. Now, prompt bowel motility, usage of nasogastric tube and multimodality ILS prevention is done, and resume oral diet within after 4 hours of post-operative status. Basically, say after the anesthesia is weaned off, right? Now, this is your IRAS protocol. Another question that was asked is pre-operative antibiotics should be given when? Remember, pre-operative antibiotics is given 60 minutes prior to incision. It is given 60 minutes prior to incision. It is given 60 minutes prior to incision. Okay? So these are the components that you should remember with respect to the IRAS protocol. So answer here is going to be D for Delhi. Pehla question clear hai? ठीक है. So what is IRAS? It is an enhanced recovery after surgery. Pre-operative में दो points है जो आप usually भूल जाओगे. एक है कि nil per oral, that is NPO status before the surgery कितना maintain करना है. Solids के लिए 6 hours है, clear liquids के लिए 2 hours है. Carbohydrate loading करानी है 100 grams prior to surgery, that is at night देनी है, और 50 grams 2 hours before the surgery has to be given. और remember इतना याद रखना, NPO status जो break करना है after the surgery, it is going to be after 4 hours. Alright? ठीक है, चल. So that is your question number 1. Let's go to question number 2. Now question number 2 says identify the instrument given below. बेटा ये जो questions है, they'll keep popping you again and again. देखो, it cannot be a Zerni's retractor क्योंकि Zerni's will have two ways. Zerni's retractor जो है, it will be having two way. On the second way, you will have two fangs here and one fang here. तो एक एंड पे लैंगनबैक है, दो एंड दूसरे एंड पे ऐसे यू विल हैव क्लॉ, दैट इज कॉल्ड एज Zerni's retractor. देखो, Morris retractor can be, because Morris retractor will only have this. Cat's paw retractor जो है, at the end you will have like this, the 3 paws like a cat's paw you will find. Doyne's retractor जो है वो curved होता है. Doyne's is going to be curved, it is not going to be straight, right? Doyne's retractor is going to be curved, it is not going to be straight. Looking at the image, I can say it is your Morris retractor. It is your Morris retractor. ठीक है, अच्छा. Let's identify. Now, whenever we talk about in the exam, they'll ask you about basic surgical positions. ठीक है. बेटा फर्स्ट क्वेश्चन में वो पूछ रहा है false क्या है ना, which of the following statement is false. Statement B is correct. No, IRAS protocol we use it for colorectal, any bowel surgeries, you know, we can use it for all bowel surgeries. ऐसा कोई if and but नहीं है. Okay, come back here. Basic surgical position. Supine position is the most common position if you are doing an abdominal surgery. Prone positions are done for your spine surgeries as well as your perineal surgeries. Lateral decubitus is done for your thoracotomies and renal surgeries. Lithotomy, obviously, all your bottom surgeries, which are called as the perineal surgeries or your urology procedures, you can do lithotomy position. Jackknife position, aaj ke date pe we don't use it much longer because it increases the risk for asphyxia. Jackknife is increased risk for asphyxia, so we don't usually, it's a prone position, but it is going to be split open. Lloyd-Davis is what we use for all your endothoracic procedure. देखो, what is the difference between lithotomy and Lloyd-Davis? Lithotomy position में ये hip और जो इसका angle है, that is going to be the hip angle is at a 90 degrees. Here you will have a more obtuse angle at a 30 degrees. ठीक है? So the hip का जो extension है, it is at 15 degrees. And then you have a table tilt down at a 30 degrees. All your endo-uro procedures. Now, if the head is down in this position is Trendelberg. If head is up, it is called as reverse Trendelberg. Okay? It is a reverse Trendelberg. Then you have your Fowler position for your cranial surgeries. Very important. This they'll ask you again and again. What is this Rose position? Rose position is for all your neck surgeries, especially for your thyroid surgeries. How do you create Rose position? By hyperextension of the neck. How do you create the hyperextension of the neck? By putting a pillow between the shoulder blades. Okay? Now this is your Sims position where you have patient in a semi-prone position with the limb flexed on one side. This is where you do your rectal examination. So it is a midway between prone and lateral position. It is the most common position used for digital rectal examination. Then you'll see blades, right? In surgical blades, remember 11 number blade is for the INDs and arteriotomies. 15 is for precision incision, 22 is for thoracotomy and laparotomy. Blade number 12 is going to be for suture removal. Suture removal के लिए you got a crooked blade, that is called as blade number 12. फिर आपके जो instruments identify करने के लिए, this is your needle holder called as a Mayo-Higgins needle holder. You cannot miss across it. छोटा माउथ होगा, that is easy to remember. Ratchet present होगा. This is your Mayo-Higgins needle holder. Now, when you're suturing smaller structures like arteries, no, the needle holder is becoming too big to handle. तो क्या करोगे? You will use this specialized one, which is called as a Castrovigi needle holder, है ना? अब if you have tissue holding forceps, shorter one is called as the Adson's tissue holding forceps. Longer one is called as the Gillies tissue holding forceps. Now, if you don't have the teeth, देखो Gillies में आपको teeth मिलेगा. It's like two fangs and a teeth like this. If there are only serrations, no teeth, this is called as the Brown Adson's forceps. There only serrations are there. You can see there's only serrations. There are no teeth here. This is a Brown Adson's forceps. अगर कोई tooth नहीं है, Gillies की तरह ही लग रहा है लेकिन longer है. It is DeBakey's and this is your curved artery forceps, which is Adson's forceps. Sinus forceps और your tissue holding forceps में या फिर needle holder में कैसे differentiate करोगे? Sinus forceps does not have a ratchet. Sinus forceps does not have ratchet. Alice forceps is for tissue holding. It will have interlocking mechanism like this, like a finger blades. Babcock's is to hold bowel, appendix hold करने के लिए Babcock's use करते हैं. ये जो triangulated ends दिखेंगे, this is what we call as dual lung holding forceps. They are atraumatic forceps. Then you have, this is you, if you say oval shaped structures here, this is a sponge holding. Sponge holding में ratchet present होता है. Sponge holding में ratchet present होता है. अगर ratchet absent है, if the ratchet is absent, looking like a sponge holding, this is your ovum holding forceps. The difference between sponge holding and ovum holding is sponge holding में ratchet present है, ovum holding में ratchet absent है. Then if you see this retractor, this is your Devas retractor, this is your standard Langenbach retractor. थोड़ा broad हो जाएगा तो Morris retractor. Zernies, I told you, one end it looks like Langenbach, other end you have fangs. This is your Zernies retractor. Doins will have a curvature. You can see there's a nice curvature here. This is your Doins retractor, and this is your Jawl's self-holding or self-retaining thyroid retractor. Everybody knows this. This is all your head and neck surgery and doing it for self-retaining. It is your mastoid retractor. This is your Golliger's abdominal self-retaining retractor. These are Mayo scissors, and this you can see on one end you have Langenbach, other hand you have paw. This is your cat's paw. This is what you call as a cat's paw retractor. Okay. So we have revised all the important instruments that are required, including the OT procedures. The answer here is going to be a Morris retractor. Clear hai? Good to go hai ji? Good to go? ठीक है? Sorted? Great. Chalo. So all these positions and all the instruments, you have to just quickly revise it. Don't worry about it. Anyhow, I'll be sharing the PDF also. Agar thoda fast ho gaya hai, don't worry about it. You can revise it at your convenience, but these are the carry-home messages that are important. Let's go to question number 3. In question number 3, it is to identify the surgical knot given in the image, right? So when you look at this, I always tell you to identify the loop first, ठीक है? तो ये आपका loop है. Now you identify the thread. One thread is going under the loop, another thread is going over the loop. अगर एक loop के नीचे से और एक loop के ऊपर से जा रहा है, if one is going below, one is going above, this is what we call it as granny's knot. This is what we call it as the granny's knot. And remember, granny's knot is an example of an unstable knot. This is an example of an unstable knot. So ये जो answer हो जाएगा, this is going to be B for Bombay, that is your granny's knot. What are the other knots? वो भी देख लेते हैं quickly. Okay, one second guys. My chat box got exited. Give me a second. Now, again, your revision material for suturing rule is this. Now, first of the suture rule, let's quickly look at this. In the suture rule, what is the length of the suture material required to suture the wound? Quick feedback, guys. फटाफट बताओगे. ये सारे ऐसे quickly finger to finger हो जाने चाहिए, right? What is the length of the suture material required to suture a wound? It should be 4 times the length of the wound. It is 4 times the length of the wound. It is 4 times the length of the wound. Now, wound is 10 centimeters, 40 centimeter का thread लगेगा. What is the distance between two sutures? Distance between two sutures should be twice the depth of the wound. It is twice the depth of wound. Question number 3. What is the angle between the needle and the skin at the entry point? It is 90 degrees. Now, what is suture memory? Suture memory is where you have coiling, right? Now, remember, suture memory for monofilament will always be more when compared to polyfilament. Suture memory is going to be more for monofilament when compared to polyfilament. Remember, a high suture memory indicates unstable knots. high memory equals unstable knots. Okay. Okay. Suture removal period is important. If you have put the suture on the face, what is suture removal period? It is 3 to 5 days. It is a 3 to 5 days. If you have put in your scalp and arms, for scalp and arms, it is going to be 7 to 10 days. It is a 7 to 10 days. Now, if you have put in the trunk, legs, hand and feet, if you have put the sutures in the trunk, legs, hands and feet, then it's 10 to 14 days. It is a 10 to 14 days. For palms and soles, it is 14 to 21 days. The maximum is for palms to soles, that is a 10 to 14 to 21 days. Okay? Chalo. Now identify the suturing technique. This is a simple interrupted suture, as you can see, single knot on one side. This is a simple continuous. You start from one end, you run completely, and then you knot on the other end. Now this is the mattress suture. Now inme se na, which is a vertical mattress, which is a horizontal mattress. Now all that you have to do is draw the line that goes along the wound and draw the line that goes along the suture line. If they are perpendicular to each other, this is your vertical mattress. This is your vertical mattress suture. Now, if you see here, the line of the wound and the suture line, they're running parallel to each other. When they run parallel to each other, this is your horizontal mattress. This is your horizontal mattress, right? Now, if it runs in the dermoepidermal junction, not on the surface of the skin, this is what we call it as the subcuticular sutures. Now, if I ask a question, best cosmetic outcome, the best cosmetic outcome. The best cosmetic outcome is going to be with the subcuticular sutures. It is going to be with the subcuticular sutures. Now you look at the various knotting techniques that you have. Knotting technique number 1, knotting 2, knotting 3, knotting 4. The first is what we call it as half hitch. It is a single loop. Now here you can see one loop on top, one other on the bottom. As I just explained it to you, this is your granny's knot. This is your granny's knot. But if both of them are under, that is, you can see both of them are under the green thread or both of them are above the red loop. So both the threads above or both the threads below. Both the threads above the loop or both the threads under the loop is what we call it as the reef or a square knot. This is called as a reef or a square knot. When you come back here, you can see there are loop number 1, loop number 2 loops on bottom, 1 loop on top. And when you observe, it will also same like a reef knot. 2 threads either under or over the loop. Now, this is what we call it as the surgeon's knot. This is what we call it as the surgeon's knot. Remember, your granny's knot and half hitch. Your half hitch and the granny's knot, they are unstable knots. They are unstable knots. Your reef or a square knot is stable, and surgeon's knot is the most stable knot. This is the most stable knot. This is the most stable knot. Okay. Clear with all the techniques, suturing rule, right? Suturing method. You have knots, types of knots, and their essence. Clear है सबको लिए? ठीक है? Sorted. All right. Can we move on? That was the question number. कौन सा question होगा? Question number 3. ठीक है? Let's move on. This is a question number 4. Question number 4. Question says, I have a neonate presented to a pediatric surgery OPD with a bilious vomiting. ठीक है? Okay. The following finding was seen in an erect abdomen X-ray. What is your objective? Right? Now, when you talk about the whole scenario of pediatric vomiting, by now you would have been clear that you have 2 bubbles which are present here. This is the bubble number 1 that you have. This is your duodenal bubble and this is your gastric bubble. So I can clearly tell you that you're looking at a double bubble sign. है ना? Now, when you see the double bubble sign, I know you know of two objectives that you have a double bubble. Now, when you have a double bubble sign, for a neonate, double bubble sign on an X-ray indicates of either a duodenal atresia, either it is a duodenal atresia, or it is your annular pancreas. The two conditions which will present to you as double bubble sign. At the birth, it is going to be duodenal atresia and annular pancreas. Correct. Now, let's look at each individual option. The congenital hypertrophic pyloric stenosis cannot be the answer because of two reasons. Number one, it is seen between 3rd to 6th week. And more importantly, it will have a non-bilious vomiting. It will have a non-bilious vomiting, not a bilious vomiting. Duodenal atresia can be a possibility. Jejunal atresia will have triple bubble. Will have triple bubble sign. The ileal atresias will have multiple air fluid levels. So by the objective only, I can tell you it is your duodenal atresia. There is no if, there is no but. All of you have gotten it correct. Now, I've given you a small table to decode all these three in a quick succession. Now, if you have a vomiting in a 4-week-old child, and if that vomiting is non-bilious, if that vomiting is non-bilious, it is projectile in nature. It is projectile in nature, and you see a single bubble. If you see a single bubble on an X-ray, then the diagnosis here is going to be CHPS, that is congenital hypertrophic pyloric stenosis, right? Management for CHPS, the first line management, remember, it is always the electrolyte correction. And if they ask you which is the most important electrolyte to be corrected, it is chloride to be corrected first. After chloride, it is going to be potassium. It is not potassium first. Okay, the chloride has to be given objective. Now, once it is done, the second line management is the surgery. And the surgery of choice is going to be Ramsted's pyloromyotomy. It is your Ramsted's pyloromyotomy. It is your Ramsted's pyloromyotomy. Okay. So this is your scenario number one. If there is a vomiting on day 0, day 1, if that vomiting is bilious, it is non-projectile. It is non-projectile, and you see there's a double bubble sign. If there's a double bubble sign, the diagnosis usually goes in favor of duodenal atresia when compared to annular pancreas. When compared to annular pancreas, the management in either condition is going to be duodenostomy. It is a duodenal, right? Just to be very clear, what is the investigation of choice in CHPS? It is the ultrasound. I hope everybody knows in the ultrasound your cervix sign, antral nipple sign, the length should be more than 16 millimeters, the width should be more than 4 millimeters. That's the criteria that we follow. Here, a plain chest X-ray is good enough, but if you want to differentiate between these two, that is duodenal atresia and annular pancreas, then it is your CCT. Then you come to the third scenario, day 0, day 1 of life. Here again, the baby will have bilious vomiting. This is going to be non-projectile. On the X-ray, you can see there are 3 bubbles, bubble number 1, bubble number 2, bubble number 3. So it's a triple bubble sign. It is your triple bubble sign. And triple bubble sign, by diagnosis, it is going to be your jejunal atresia. And for jejunal atresia, management is jejunostomy. The management is going to be jejunostomy. We do jejunostomy. Okay? Sure. So this one table will solve all your problems with your neonatal vomiting. So far so good. Okay? Can we move on? Chale. Chalo. Question number 5. Now in question number 5, I have a 2.5-year-old child brought to the casualty department with severe abdominal pain. Okay. He is taken for emergency exploratory laparotomy, alright, where the finding shown below is noticed. Okay. Now, based on this, which of the following statement is false regarding this condition? Now, I have a 2.5-year-old child, right? And then he's brought to casualty department, severe abdominal pain, taken to emergency, laparotomy is done. The finding is shown, noted. Now, what are you able to see? Right? There's an eroded surface of the bowel on the antimesenteric surface. It's a diverticular space that is created, right? Now, this condition, now this is basically a Meckel's diverticulum, right? So as you can see, diverticular space with erosion is present. Now this condition is most common presenting symptom in younger children is bleeding. Actually for Meckel's diverticulum, the most common presenting finding is going to be bleeding, correct. Now it's a false diverticulum is wrong. Meckel's diverticulum is an example of a true diverticulum. And this is from the antimesenteric side. This statement is correct, but it is not a false, it's a true diverticulum. The most common heteropic tissue is gastric mucosa. This is also correct. It acts as a lead point for intussusception. This is also correct, right? So this is a diagnosis as Meckel's diverticulum. We all know rule of 2 here. Option B is wrong because Meckel's diverticulum is an example of a true diverticulum, not a false diverticulum, right? Now, most of the babies of Meckel's diverticulum will present to you with bleeding manifestation because of peptic ulcer disease in the ectopic gastric mucosa. We have already dealt with that. है ना? चलो. It's misbehaving a bit. चलो. Question number 6. Now, I have a 3-month-old baby brought to the OPD for a facial defect. You can see there's a cleft lip present. On examination, following findings are noticed. The soft and the hard palate are intact. Out of the following option, which is the most appropriate management for this child? Now, for every single time we tell you about cleft lip and cleft palate. Now, remember, if there is a unilateral cleft lip, if there is a bilateral cleft lip, if there is a soft palate, and if there is a hard palate, which is clefted. For unilateral cleft lip, we do a single surgery between 5 to 6 months of age for correction. For bilateral, I will do a single surgery, but this time I'll do it slightly earlier, that is between 4 to 5 months. Soft palates are repaired at 6 months of age and hard palates between 15 to 18 months. Now, this is the only data that you have to remember. Whenever there's a combination, you'll think about both of them together, right? Now, you come back here. You have 3-month-old baby brought to the OPD. So it's a unilateral cleft lip. It's not a bilateral cleft lip, it's a unilateral cleft lip. Unilateral cleft lip, single surgery can be done between the age of 5 to 6 months. Now, immediate is wrong. 9 to 12 is wrong. 12 to 15 is wrong. What matches our option is option B, that is going to be 4 to 6 months. Clear? Is that clear? ठीक है, इससे easy question हो ही नहीं सकता. Just remember this data. This is what you have to remember for the exam. So far, so good. ठीक है, चलो. Going on to question number 7. Now, I have a 40-year-old patient presented to the emergency with abusive speech. When I say abusive speech का मतलब क्या होता है? It is inappropriate. It is an inappropriate speech. Now, inappropriate में 3 P है, तो score of 3 has to be given. ठीक है. Now, there's an abnormal flexion. Now, when there's an abnormal flexion, if there's an abnormal flexion, that means it is decorticate rigidity. It is a decorticate rigidity. Now, for a decorticate rigidity, see when you have a score of 1, it is no motion, decerebrate, decorticate. So, score of 3 is given here also. Correct? Now, the next one that you have, eye opening is on pain, right? So, when you talk about the eye opening, when you look at the eye opening, now when you're talking about eye opening, spontaneous is a score of 4. Okay? Speech is 3 and painful stimulus is 2. So, this is a total score that you have. How much is that? 3, 6, 2, 8. So, the total GCS that you have gotten here is 8 upon 15. So, answer here is B for Bombay. B for Bombay. Okay? Now, remember, when you talk about in terms of GCS, I've given you here how do you calculate it. Just for your references, everybody knows it. But remember, in terms of GCS, if they ask you a question, the first question would be, what is the maximum GCS? Everybody knows it is 15 by 15. What is the minimum GCS? That is going to be 3 by 15. When would you like to intubate? Criteria to intubate based upon GCS, if it is less than or equal to 8 by 15. What is a GCSP score? Now GCSP, we assess pupil score. In pupil score, if bilateral pupil responsive, score of 0. If unilateral pupil responsive, score of -1. If bilateral pupil non-responsive, then a score of -2 is given, right? So this is the additional finding that they can ask you if they want to make your life difficult. Okay? So here the answer is B for Bombay. Everybody knows it. Question number 9. In the question number 9, they're asking you TRISS includes the following. Now for this, I will tell you 3 important comments. Number 1 is RTS scoring system, that is a revised trauma score. For this, you remember GBR. That is great. G stands for Glasgow Coma scale. P is your systolic blood pressure. R is your respiratory rate. For TRISS, you remember as RAM. That is a trauma and injury severity score. It is going to be RAM. R stands for RTS scoring system. That is your GCS, systolic blood pressure, respiratory rate. A is your age of presentation. M is the mechanism of injury. M stands for the mechanism of injury. Then you have your mangled extremity scoring system, MES score. For MES, you remember the mnemonic as ELISA. E is the energy with which the injury has occurred. LI is status of limb ischemia. LI is the status of limb ischemia. S is the status of shock, and A is the age of presentation. A is the age of presentation, right? Now, looking at all this, they're asking TRISS में what is the components? TRISS में RTS age mechanism, ठीक है? Okay, GCS is there, blood pressure, respiratory rate, ये तो सिर्फ आपका RTS scoring system हो गया. RTS with injury severity score and age of presentation, ठीक है? RTS with injury severity score. So GCS is already a part of RTS, so it cannot be there. RTS and GCS cannot be together. Answer here is B for Bombay. B for Bombay. Clear है? ठीक है? Great. Going to question number 10. Now, sometimes see in the exam every single day it will not be like easy peasy walk. कभी कभार ऐसे bouncers भी पढ़ेंगे, उसके लिए you have to be prepared. The question that they ask you is about the abdominal compartment syndrome. ठीक है? So let's quickly look at the abdominal compartment syndrome. They're asking which of the following are true about the abdominal compartment syndrome. एक बार quick recap कर लेते हैं ये abdominal compartment syndrome क्या है. So we talk about abdominal compartment syndrome. In the abdominal compartment syndrome, the first one is what is the normal intra-abdominal pressure? It is 9 to 11 millimeters of mercury, more than or equal to 12. If the intra-abdominal pressure is more than or equal to 12 millimeters of mercury, then we call it as intra-abdominal hypertension. We call it as the intra-abdominal hypertension. Now, to make your life difficult, they'll ask what are the different grades that you have. You have grade 1, you have grade 2, you have grade 3, and you have grade 4. So, what is grade 1? Grade 1 is going to be between 12 to 15 millimeters of mercury. It is grade 1 intra-abdominal hypertension. 16 to 20 millimeters of mercury is grade 2. 21 to 25 millimeters of mercury, it is your grade 3. And if it is more than 25 millimeters of mercury, that is your grade 4 intra-abdominal hypertension, right? Now, when do you call it as an abdominal compartment syndrome? We call it as ACS. For an abdominal compartment syndrome, the intra-abdominal pressure should be more than 20 millimeters of mercury. So more than 20 millimeters of mercury with new organ dysfunction. With a new organ dysfunction that is observed here. This is what we call as abdominal compartment syndrome. Okay. Now, abdominal compartment syndrome is seen after trauma. It can be because of bowel edema. All that is there. Okay. Okay. Come here. Now, which of the following are true about the abdominal compartment syndrome except it is more than 20 millimeters of mercury pressure? This is a true statement. It decreases the pulmonary venous pressure. We'll come back to it. Intra-abdominal pressure measured using Foley's catheter of the bladder. Yes, when you measure the bladder pressure, it indirectly tells you the intraperitoneal pressure. That is going to be how you measure your compartment pressure. with more than 25 to 30 millimeters of mercury intra-abdominal pressure, life-threatening hypoxia and ARDS can occur. Now, 2 points which are slightly difficult for us to understand. Let's try to comprehend. Decreased pulmonary venous pressure. Okay. Now, what do you mean by this? Obviously, when the pressure inside the abdomen will increase, what will happen to the IVC? The inferior vena cava is going to get compressed. If the IVC is going to get compressed, what will happen to the venous return to the heart? The venous return to the heart is going to decrease. If the venous return will decrease, what will happen to the preload in the right ventricle? The right ventricular load is going to decrease. Now, right ventricle is now going to pump the blood into the pulmonary artery. So, what will happen to the pulmonary artery pressure? The pulmonary artery pressure is going to reduce. Now, this is what they're asking you. What will happen to pulmonary venous pressure? Now, obviously, if the arterial pressure is dropped, that is blood going back, right? So, what is going to happen? Obviously, the blood going back into the heart will also become less. Obviously, the pressure is going to be dysregulated there. Now, if with a more than 25 to 30 millimeters of mercury, life-threatening hypoxia and ARDS can occur. I'm not saying it is life-threatening ARDS or hypoxia can occur. It will cause severe preload issues, right? So, obviously, this is correct statement that we have just discovered it. So, answer here is going to be D for Delhi. Okay. Obviously, pulmonary pressures are going to reduce because the blood going to the lungs will decrease. अगर lung के अंदर जाने वाला blood कम है तो lung से आने वाला blood भी जो आ रहा होगा heart में वो भी कम होगा. तो pressure in the pulmonary vein will also decrease. ठीक है. So answer here is D for Delhi. This is what you have to remember from the exam perspective. The readings of intra-abdominal pressure. ठीक है. Clear है? So far so good. All right, can you move on? This was our question number 10. Going on to question number 11. In question number 11, I have a 40-year-old female presented with bloody nipple discharge, right? So whenever I use the word bloody nipple discharge, you should know the sequence. In a bloody nipple discharge, the most common is going to be duct papilloma. If this is not in the option, then it is your ductal carcinoma. If it is not in the option, then it is your duct ectasia. Now, this is the sequence that you have to remember. Okay. The minute the question starts, your brain should start thinking in these lines. Okay. Now, it says bloody nipple discharge. On evaluation, a diagnosis of ductal papilloma of the breast was made. Okay. What is the treatment of choice for duct papilloma? We all know for duct papilloma, the surgery that we perform is microdocectomy. The surgery of choice is what we call it as the microdocectomy. So in microdocectomy, we remove the major lacticiferous duct. We're going to remove the major lacticiferous duct associated with papilloma. Just not the papilloma, but also the major lacticiferous duct is removed. So answer यहाँ पे clear हो गया. It is B for Bombay. Remember, simple mastectomy is done for malignant phylloids. For malignant phylloids tumor, and another one is early breast cancers. That is stage 1, 2A and 2B. For breast cancers, you can do simple mastectomy. Okay. Wide local excision is done for benign phylloids. And there is no role of chemotherapy in benign disorders. Okay. So here answer is going to be for Bombay. Question number 12, it is a straightforward question. Which of the following is associated least risk for development of breast cancer? We all know BRCA1, BRCA2 are the top risk. So this you remove out. Lee-Formey syndrome is P53 mutation. This also causes it. So the only thing that you don't know is telangiectasia. So mark that. That is going to be the least possibility for development of the breast cancer. End of discussion. That is question number 12. Question number 13. This is what we've been cribbing all across our life. Let's quickly look at this. I have a 48-year-old woman presents with a 7 centimeter breast lump. The minute I say 7 centimeter breast lump, I know what is T1 less than 2 centimeters, T2 is 2 to 5 centimeters, T3 is more than 5 centimeters, so it's a T3 disease. Now read the question completely. Now adherent to the skin, okay, one hard apical lymph node in the axilla. That is saying adherent to the skin is there and the axillary lymph node is involved, and one additional node in the ipsilateral supraclavicular region. Okay. Now, the minute they say supraclavicular region, You have lymph node positive in supraclavicular region. It is going to be N3C. ठीक है, and there is no sign of clinical, distant metastasis. अगर distant metastasis नहीं है, तो I can simply say it is an M0 disease. Now, I don't know about all this. ठीक है, the shortcut that I remember is how do you differentiate between 3A, 3B, and 3C? I know it is an N2 disease, T4 disease, N2 disease, T4 disease, and an N3 disease. ठीक है, अब मेरे पास क्या है? N3 disease है, तो it is going to be 3C. It is going to be 3C. So anybody who has done breast cancer with me, you cannot go wrong in this. It is going to be a 3C disease. So what is going to be the entire disease? It is going to be, look at with N3C. There's not N3C here. There's no N3C here. There's no N3C here, right? So I would see N3C is here. You would say whether you should go with 3 or 4. Now you say adherent to the skin, right? That means the skin involvement is there, right? Adherent to the skin, if I'm taking a skin involvement, skin involvement, will call it as what? If I say skin involvement is present, presence of skin involvement will directly become T4B disease. But how do you know skin is getting involved? Either there has to be ulceration or there has to be Peutz-Jeghers orange. Either there has to be ulceration or Peutz-Jeghers orange. Remember, you cannot call it skin involvement if there's dimpling. So dimpling does not alter the stage. Okay? Dimpling is not skin involvement. Just remember here, dimpling is not skin involvement. Now you're caught up with two options. I know those are the two options that we have, a slightly difficult one to choose. Whether you'll go with T4 N3C M0 or T3 N3 M0, which one do you think is the right option? But adherent to the skin is not equal to skin involvement. It has to mention in the question that there has to be ulceration and Peutz-Jeghers orange. Did it say ulceration and Peutz-Jeghers orange? Did it give you ulceration and Peutz-Jeghers orange? Yes or no? Did it in the question, does it say that there is ulceration or Peutz-Jeghers orange? It just is adherent to the skin, right? The lump appears to be adherent. Dimpling also appears to be adherent to the skin, no? Right? So here the better answer will go with T3 disease, because they have not mentioned ulceration or Peutz-Jeghers. That's the only reason I'm not picking that up. N3 disease is there, which is N3C obviously. So I'll say T3 N3 M0. I'll go with option D. Okay? I'll go with option D. Clear hai? Got it? Beta, see, in the breast cancer, they'll always try to confuse you with the skin involvement. How do you know the skin is getting involved in a lump or not if there is an ulceration of Peutz-Jeghers orange? अगर ये दो points mentioned है, तब मैं skin involvement मानूंगा. Skin immobility or skin adherence is not equal to skin involvement, क्योंकि dimpling में भी skin involved लगता है. Is that clear? Please do not goof up in that. Clear? Chal. This is a good question. Question number 14. Question number 14, you are posted in surgery OPD. A patient presents to you with the below depicted swelling. There's a swelling in the midline of the neck, right? So you can see there's a swelling which is present in the midline of the neck. It looks like a very globular swelling, right? Okay. On examination, swelling moves with tongue protrusion. The minute you know the swelling is moving with tongue protrusion, I know it is going to be thyroglossal duct cyst. So the diagnosis for this condition is going to be thyroglossal duct cyst. And the most common site for the thyroid duct cyst is your subhyoid region. It is in the subhyoid region. Okay. Region of the thyroid cartilage, no. Suprahyoid at the level of hyoid, infrahyoid. See, when I say of these, suprahyoid is least likely. At the level of hyoid is again least likely. Sub or infrahyoid is what you have to pick. If you don't have, see, ideally it is to be subhyoid. अगर सब हायर्ड ऑप्शन नहीं है, you can pick infra hired also. So answer here is going to be D for Delhi. ठीक है, correct. What is the surgery of choice, guys? Surgery of choice for thyroid duct cyst, it is your cis trunks operation. Now we also know thyroid duct cyst increases the risk for what? Papillary cancer thyroid. It increases the risk for papillary cancer thyroid. It increases the risk for papillary cancer thyroid. ठीक है, चलो. Going into question number 15. Now I have a 55-year-old woman featured with hypothyroidism and hypoparathyroidism. ठीक है. Presents a surgery OPD with a painless heart enlargement in the neck. She underwent open thyroid biopsy, which helped the senior resident diagnose Riedl's thyroiditis. ठीक है. This is a Riedl's thyroiditis. The following is not used in the management. See, Riedl's thyroiditis, when you talk about it, Riedl's thyroiditis, it is, when compared to comparative data, it is more idiopathic when compared to autoimmune. If it is autoimmune, then it is associated with IgG4 class of antibodies. It is associated with IgG4 class of antibodies. Achha. Second, it is associated with autofibrosis. Now, because of autofibrosis, it will have dense adhesions. It is dense adhesions with surrounding tissues, with surrounding structure. They are associated with pressure symptoms because the gland enlarges. Now, because it appears to be large, exerting pressure, the most common differential diagnosis for Riedl's thyroiditis is your anaplastic cancer. It is your anaplastic cancer. It is your anaplastic cancer. Riedl's thyroiditis is inoperable. It is inoperable. So management here is going to be lifelong thyroxine. It is the lifelong thyroxine. If the patient has severe pressure symptoms, then the surgery of choice to relieve this is going to be hysterectomy. The surgery of choice here is going to be hysterectomy to relieve pressure symptoms. To relieve the pressure symptoms. Okay? Which of the following is not used in the management in this condition? There is no pain, so why will I use NSAIDs? Steroids can be used. Tamoxifen is found to be a little bit helpful in these contexts. And thyroxine, obviously, you have to give the patient. So answer here is going to be A for Ahmedabad. It is a for Ahmedabad. Okay? Chalo. Question number 16. This is a spotter. Which of the following is seen in the thyroid carcinoma? This is your orphan ani nuclei. This is your orphan ani nuclei. Presence of orphan ani nuclei. This is empty vacuolated cells. This is your orphan ani nuclei. Orphan ani nuclei is a characteristic feature of papillary cancer thyroid. It's a papillary cancer thyroid. So answer here is going to be C for Calcutta. See, Hurthal and follicular cells will have Ashkenazi cells, anaplastic will have multiple smaller cells. So the characteristic, if they're giving, in the thyroid cancer, there'll be two images. Either they'll give you this empty vacuolated cells, that is orphan ani nuclei. The other thing that you'll see in papillary cancer thyroid is going to be samoma bodies, which are dystrophic calcification. And in medullary cancer thyroid, you'll see presence of amyloid in stroma. Okay? So that's the carrier message that you need to go across here. Here the answer is papillary cancer thyroid. I hope everybody is clear in that context. No if and but. अच्छा, एक क्वेश्चन जो एडिशनली पूछ लेगा वो आपसे, अगर ज्यादा ज्यादा पूछेगा कि पैपिलरी कैंसर थायराइड में व्हाट आर द एचपी फाइंडिंग्स. एक तो वी ऑलरेडी नो देयर इज एन ऑर्फन एनी आई न्यूक्लियर. वी हैव एन ऑर्फन एनी आई न्यूक्लियर. ठीक है, एक और बता दो. वन मोर दैट वी जस्ट डिस्कस्ड, that is going to be your samoma bodies. Samoma bodies are example of dystrophic calcification. These are the examples of dystrophic calcification. These are the examples of dystrophic calcification. Now, conditions where you can see the dystrophic calcification can be remembered by mnemonic. that is your PSM. ठीक है. P stands for the papillary variant of renal cell carcinoma. S stands for serous cyst adenoma. Serous cyst adenoma of ovaries. And M stands for meningioma. M stands for meningioma. Okay. So this is the sum of what is that you'll see. Another, let's say if you are so well prepared, give me this answer. What is the third finding that you'll see on an HP? There's presence of grooving of cells. This is seen in any malignant tissues, where the cells are proliferating, they just compress each other. Another thing that they can ask you in medullary cancer thyroid, what is the finding? In the medullary cancer thyroid, remember, they will present to you in medullary cancer thyroid, they will have amyloid in stroma. Presence of amyloid in stroma. Okay. So these are the other objectives that you should remember. Okay. Going on to the next question, that is question number 17. In the question number 17, during a parathyroidectomy, okay, the surgeon measured the parathyroid hormone levels at multiple time points. Pre-incision, pre-removal, that is 5-10 minutes post-removal. Okay. The surgeon observed specific PTH trend and decided to explore further. Which of the following statement is best supported in surgeon decision? Whenever you see a question like this, no, in the parathyroid glands, especially when removing for primary hyperparathyroidism, there's a criteria which is called as the Miami criteria. Miami criteria basically tells you whether you have removed the diseased gland or not. To identify if diseased gland is removed or not. So how do you know that if the diseased gland is removed or not? So what we'll do is, we measure the parathyroid hormone levels. We measure at 5-minute mark, we measure at a 10-minute mark, and we measure at 30-minute mark. What is for us to remember is a 10-minute mark. At the 10-minute when you measure, the decrease in parathyroid hormone should be more than 50% of its preoperative value. Whatever was the value of the parathyroid hormone before the surgery, more than 50% should reduce at a 10-minute mark. If this is achieved, that means you have removed the right gland. If it is not achieved, then you have to re-explore it. That is what the Miami criteria is all about. Now, it says the percentage decline won't exceed more than 50%. The percentage decline won't exceed more than percentage decline exceeds 50%. If the percentage decline exceeds 50%, that means you have done a right, you don't need to re-explore. 60%, you don't need to re-explore. 75%, you don't need to re-explore. If it is drop is less than 50%, then I would re-explore. Answer is A for Ahmedabad. Is that clear? ठीक है, बड़ा सिंपल सा क्वेश्चन है, मायामी क्राइटेरिया पे है, 2-3 बार पूछ रखा. मैक्सिमम टू मेक योर लाइफ डिफिकल्ट, दे आस्क यू व्हाट इज द इन्वेस्टिगेशन ऑफ चॉइस फॉर प्राइमरी हाइपरपैराथायरॉयडिज्म. What is the investigational choice for primary hyperparathyroidism? Quick feedback. Small controversy है इसमें, फटाफट बता दो. Answer here is going to be, देखो दो ही ऑप्शन है, सिस्टा में भी स्कैन वर्सेस 4D CT. Here it is your सिस्टा में भी स्कैन is preferred over 4D CT. If they ask you best or gold standard, बेस्ट या गोल्ड मैं 4D CT बोल दूं. बेस्ट और गोल्ड स्टैंडर्ड इज गोइंग टू बी 4D CT, अदरवाइज इट इज अ सिस्टा मे बी स्कैन. ठीक है, इसके बियॉन्ड दे विल नॉट आस्क यू एनी क्वेश्चंस. ठीक है, सो फार सो गुड. ठीक है बेटा, चलो क्वेश्चन नंबर 18. Now in question number 18, our 43-year-old man, alcoholic abuse, presents with chest and back pain after repeated vomiting, has an episode of hematemesis. ठीक है, what is the most likely diagnosis? See, post repeated episodes of vomiting with hematemesis, and you see that there are longitudinal ulcers which are present here, that goes in the favor of Mallory-Weiss tear. The Mallory-Weiss tear. Remember, the most common site for tear is going to be the cardia of the stomach. If not, then it is a gastroesophageal junction, and these are longitudinal tear. This is a longitudinal tear. Now, Boerhaave syndrome will have macular striae. Now, what is macular striae? In the macular striae, patient will have vomiting and retching. After vomiting, there will be sudden severe onset of chest pain. And after chest pain, there will be cervical subcutaneous emphysema. There will be cervical subcutaneous emphysema. It is a cervical subcutaneous emphysema. Okay? But a Boerhaave is a perforation. Mallory-Weiss is a tear. Please do not get confused in these two. Acute pancreatitis does not have hematemesis. Aortic aneurysm rupture. Patient will present with severe hypotension. Okay? Please revise Boerhaave and Mallory. Many questions in PY. But a Boerhaave or Mallory का कोई वो ही नहीं है. Okay, one say Boerhaave syndrome versus Mallory-Weiss tear. ठीक है? Okay. Let's do a quick recap between these two. क्या बला है ये? Okay. Now, the first thing, how do they start? Let's talk about the history of vomiting. The history of vomiting will be present in both of them. History of retching. Retching is dry vomitus or heave, which are present in Boerhaave, usually not seen in Mallory-Weiss tear. Now, what is the presenting feature? So, Mallory-Weiss tear, if you talk about the three symptoms that we'll talk about, hematemesis. There will be hematemesis, chest pain, and you have subcutaneous emphysema. Hematemesis will present in both of the conditions. Chest pain is seen in Boerhaave, may or may not be seen in your Mallory-Weiss. Cervical subcutaneous emphysema is not seen in Boerhaave, but it will be seen in your Mallory-Weiss tear. It's a Mallory-Weiss tear. ठीक है? अच्छा. The investigation of choice for Boerhaave syndrome is your water soluble. It's a water soluble esophageogram. Whereas this is your upper GI endoscopy. Now remember, there's a presence of perforation here. The through and through perforation will be present, and here it's a longitudinal submucosal tear. There's a longitudinal submucosal tear. If you know this, you can never go wrong between Boerhaave and the Mallory-Weiss tear. ठीक है? Clear? ठीक है? But I need a quick feedback. अकेले अकेले स्क्रीन को देख के पढ़ाना थोड़ा मुश्किल होता है यार. थोड़ा सा एक्टिव पार्टिसिपेट करो. ठीक है? तो ठीक रहेगा. Correct? Cervical subcutaneous emphysema is there in Boerhaave syndrome. मैंने क्या अच्छा उल्टा लिख दिया. Sorry. Cervical subcutaneous emphysema is seen in Boerhaave. It is not seen in Mallory-Weiss tear. उल्टा लिख दिया. Thank you. Thank you. ठीक है? चलो. So we're going to question number 19. क्वेश्चन नंबर 19 क्या? आइडेंटिफाई द प्रोसीजर शोन इन द इमेज. दिस, इफ यू आर माय स्टूडेंट, you'll never go wrong. This is your Nissen's, we call it as Nissen's fundoplication. Now, what is the Nissen's fundoplication? It is number one, a complete fundoplication. When I say complete, that means it is a 360 degrees fundoplication, and it is a posterior fundoplication. Because we got it from behind, it is a posterior fundoplication. It is a posterior fundoplication. So answer तो clear हो गया, ये Nissen ही है. देखो Ellison जो है, it is also done for GERD, but here you repair the hiatus. Ellison we only repair hiatus. Hills जो है, it is also done for GERD procedure only. लेकिन Hills में क्या? You are doing a gastropexy. आप क्या करो? स्टमक को फिक्स कर देते हो फॉर द सराउंडिंग स्ट्रक्चर सो इट कैन नॉट गो अक्रॉस. टोपिट इज ऑल्सो फंडोप्लाइकेशन. इट इज अ 270 degrees posterior partial fundoplication. ठीक है. सो आंसर हियर इज द Nissen's fundoplication. ठीक है. ग्रेट. गुड. ऑल ऑफ यू आर डूइंग गुड. ग्रेट. कैन यू गो टू द नेक्स्ट क्वेश्चन? ठीक है. क्वेश्चन नंबर 20. Now, I have a 52-year-old man brought to the emergency department with acute onset of hematemesis. ठीक है. An upper GI endoscopy reveals a large peptic ulcer located proximal to the stomach on the lesser curvature. ठीक है. On the lesser curvature. Which of the following arteries? देखो ये question ना, I mean they love this question and I also think it is a very good question to have. So let's quickly recap this. देखो जहां पे ब्लड सप्लाई होगी वहीं से ब्लीड करेगा. ये आपकी सीलियाक आर्टरी है. ठीक है. सीलियाक आर्टरी से यहाँ पे जो ब्लड सप्लाई है लेफ्ट गैस्ट्रिक आर्टरी. दिस इज योर लेफ्ट गैस्ट्रिक आर्टरी. ठीक है. एक आपके यहाँ से पीछे चली जाएगी स्प्लेनिक आर्टरी विच इज गोइंग टू बी हियर. दिस इज योर स्प्लेनिक आर्टरी. वी आर नॉट वरीड अबाउट इट. दिस इज योर hepatic artery proper that is going to go. From here you will see the right gastric artery is going to come out. तो ये आपकी राइट गैस्ट्रिक आर्टरी है, ये आपकी लेफ्ट गैस्ट्रिक आर्टरी है. कॉमन सेंस डिक्टेट्स अगर अल्सर इस लेवल के ऊपर है, इफ द अल्सर इज प्रेजेंट अबव दिस लेवल, ठीक है, इफ द अल्सर इज गोइंग टू बी प्रेजेंट एनीवेयर इन दिस एरिया, व्हाट विल बी द सोर्स ऑफ ब्लीडिंग? अगर मैं पिंक में जो शेड कर रहा हूं, अगर यहाँ पे अल्सर है, व्हाट विल बी द सोर्स ऑफ ब्लीडिंग? ऑब्वियसली लेफ्ट गैस्ट्रिक आर्टरी. अगर अल्सर इस रीजन में है, अगर अल्सर इस रीजन में है, what will be the source of bleeding? It is going to be your right gastric artery. फिर यहीं से जो आपकी कॉमन हेपेटिक आर्टरी जा रही है, एक और ब्रांच आती है जैसे गैस्ट्रोडियोडेनल आर्टरी, जो डियोडेनम के पीछे सप्लाई करी, इट गोज टू द पैनक्रियास. नाउ इफ द अल्सर इज गोइंग टू बी प्रेजेंट इन दिस रीजन, देन द सोर्स ऑफ ब्लीडिंग इज गोइंग टू बी गैस्ट्रोडियोडेनल आर्टरी. अब इसमें क्या रॉकेट साइंस है मेरे को नहीं समझ में आता. हाउ कैन यू गो रॉन्ग इन दीज क्वेश्चंस? ठीक है. अगर यही मैं बोलूं ग्रेटर कर्वेचर पे, ग्रेटर कर्वेचर पे क्या है? अगर आप स्प्लेनिक आर्टरी देखोगे, इट गिव राइज टू टू वेसल्स. ठीक है. स्प्लेनिक आर्टरी को थोड़ा सा अलाइन कर लेते हैं, थोड़ा हमने बहुत इधर बना दिया. मान लो कि स्प्लेनिक आर्टरी जो है, दिस इज वेयर द स्प्लेनिक आर्टरी इज गोइंग, इट विल सप्लाई टू द फंडस ऑफ द स्टमक. दिस आर योर शॉर्ट गैस्ट्रिक आर्टरी. तो अगर अल्सर आपके फंडस में है तो शॉर्ट गैस्ट्रिक आर्टरी उसकी सप्लाई हो जाएगी. इफ इट इज देयर हियर, this is going to be your left gastroepiploic artery, left gastroepiploic artery, and from here you see gastroduodenal artery is going to go into pancreatoduodenal artery, and then it also splits up into the right gastroepiploic artery. Agar ulcer is present in this area, this is going to be your left gastroepiploic artery, and ulcer is present in this area on the greater curvature, this is going to be right gastroepiploic artery. So there is no if and but in this. No, आप इसमें कंफ्यूज हो ही नहीं सकते. इज दैट क्लियर? ठीक है. मैंने कुछ गलत बोला? डिड आई से एनीथिंग रॉन्ग? ठीक है. लेसर कर्वेचर पे आइदर इट हैज टू बी लेफ्ट गैस्ट्रिक आर्टरी और राइट गैस्ट्रिक आर्टरी, मोस्ट कॉमनली लेफ्ट गैस्ट्रिक आर्टरी होती है, अगर ये ऑप्शन में नहीं है तो राइट गैस्ट्रिक आर्टरी। ग्रेटर कर्वेचर लेफ्ट गैस्ट्रोएपिप्लॉइक, राइट गैस्ट्रोएपिप्लॉइक। फंडस में पूछ लेगा तो शॉर्ट गैस्ट्रिक आर्टरी। अब बताओ डिओडनल में पूछ लेगा गैस्ट्रोडिओडनल आर्टरी, है ना। इसके बियॉन्ड कुछ है क्या? इज देयर एनीथिंग बियॉन्ड दिस? दिस इज द क्लैरिटी ऑफ थॉट, इज दैट क्लियर? अब एनी टाइम दे आस्क द क्वेश्चन यू नो द आंसर, यस और नो बेटा, यस और नो? ठीक है, नाउ द क्वेश्चन सेज कि व्हाट इज द मोस्ट, ये बोल रहा है लेसर कर्वेचर पे, तो लेसर कर्वेचर का सप्लाई तो गैस्ट्रोडिओडनल आर्टरी है ही नहीं, सो इट इज स्ट्राइक आउट। Pancreatoduodenal artery is also not supplying to the lesser curvature, strike this out. Left gastric artery will supply, right gastroepiploic artery supplies to the greater curvature, ये clearly lesser curvature बोल रहा है। Looking at the blood supply only I can tell you the answer is C for Calcutta. You don't need to even know this answer, common sense question है ना? Got it? चलो, question number 21. I have a 50-year-old woman presents to the emergency room with sudden onset of severe abdominal pain begin in the morning. She has a history of peptic ulcer disease. ठीक है. On physical examination, epigastric tenderness, general abdominal rigidity is there. The minute you see this word board-like rigidity, I know it is perforation peritonitis, right? So the diagnosis I've already made it. It is going to be perforation peritonitis. It's a perforation peritonitis. All hollow viscous perforation can present to you. ठीक है. Positive Murphy's sign. ठीक है. Murphy's is present positive in all inflammatory disorders. ठीक है. Radiograph is given. Radiograph में क्या है? Free gas under right hemidiaphragm. I see there is free gas under right diaphragm. I see free gas under right hemidiaphragm. You can see here. This is the diaphragm that you can see. This is the liver shadow that you can see. In between the diaphragm and the liver, there is air that is present, right? So free gas under right hemidiaphragm. It's a hollow viscous perforation. It is not acute cholecystitis. In acute cholecystitis, what is the triad for acute cholecystitis? There will be pain, fever, and leukocytosis. Okay? So don't worry about it. It cannot be Boerhaave syndrome. Boerhaave syndrome mein there is air in the subcutaneous plane. It is not, Boerhaave is not an intra-abdominal perforation, it is an intrathoracic perforation. Gastritis won't look like this. Okay? It's a perforated peptic ulcer disease which is going to present to us perforation peritonitis. It's a perforation peritonitis. Okay? Alright. Investigation of choice is going to be erect X-ray abdomen. And the surgery of choice is going to be Graham's omental patching. It is a Graham's omental patching. Okay? Going to question number 22. Now, based on the Johnson's classification of gastric ulcer, which of the following type is associated with hypochlorhydria? तो पहले तो ये देख लो ना, what is type 1 ulcer, what is a type 2 ulcer, what is a type 3 ulcer, है ना, what is a type 4 gastric ulcer, right? So what is a type 5 gastric ulcer? Type 1 क्या है? It is on the lesser curvature, that is antrum of the stomach. Antrum of the stomach on the lesser curvature. This is a type 1. Type 2 क्या है? One is present on the body of the stomach. Another one is on the first part of the duodenum. Type 3 is going to be pre-pyloric. Type 4 is high on lesser curvature. And type 5 is going to be NSAID-induced gastric ulcer. Now, which of the following type is associated with hypochlorhydria? ठीक है? Okay, what is this hypochlorhydria? Hypochlorhydria कब होगा? When you have destruction of the parietal cells. ठीक है? One second, guys. Sorry, I'm getting few messages from the hospital. See, got it. Sorry. Come back here. So the modified Johnson's classification, these are the types of the gastric ulcer that we have. Now, remember the one which is associated with excessive acid secretion. The excessive acid secretion is associated with these two. That is type 2 and type 3 will have increased gastrin. If there's increased gastrin, that means they will cause increased stimulation of parietal cells. If there's increased stimulation of parietal cells, they produce more amount of hydrochloric acid and the Castle intrinsic factor. So in these two conditions, they'll be associated with hyperchlorhydria. They are associated with hyperchlorhydria, not hypo. So I can rule out type 2 and type 3. So type 2, type 3 कहाँ पे option में है? So type 3 is there. I'm going to rule out. देखो, NSAID induced gastric ulcer is clearly telling you it is because of gastric erosion. Now, what does NSAIDs do? It inhibits cyclooxygenase. When it inhibits cyclooxygenase, it causes reduction in prostaglandins. When the prostaglandin reduces, what is going to happen? The mucus secretion decreases. So the concentration of the hydrochloric acid increases, causing gastric erosion. So यहाँ पे भी आपको hyperchlorhydria मिलेगा, right? So here, because of increased concentration of hydrochloric acid, there will be gastric erosion, and that results in ulceration. So type 5 cannot be the answer. ठीक है. अच्छा, टाइप 4 जो हाई ऑन लेसर कर्वेचर है, that is also because of excessive acid production, not because of gastrin. So again, this cannot be associated. So type 4 cannot be associated. Type 1 is associated with H. pylori. ठीक है. तो टाइप 1 जो है ये ज्यादातर H. pylori के साथ देखने को मिलेगा. Problem with H. pylori is it causes atrophic gastritis. It results in atrophic gastritis. Agreed, है ना? अगर atrophic gastritis, atrophy of the entire mucosa is going to occur. Now, when this atrophy of the entire mucosal surface will occur, the parietal cells will also get destroyed. So, in atrophic gastritis, there will be damage of the parietal cells, which will cause decrease in hydrochloric acid and decrease in Castle intrinsic factor. That is why I tell you, no, in your atrophic gastritis patient will also have pernicious anemia because of decrease in Castle intrinsic factor. Hydrochloric acid decrease हो गया तो hypochlorhydria. So one that is associated with hypochlorhydria is going to be type 1. Now this is a very conceptual but a very clear question. You know your concepts, you will be able to answer this question. Is that clear? आई बात समझ में? आई बात समझ में? Quick feedback. Yes, no, okay, tata, bye bye. क्या है scenario? Is the concept and question clear? बेटा टाइप 4 में नॉर्मो एसिडिक होता है. टाइप 4 इज नॉर्मो एसिडिक, हाइपो हाइपर नहीं होता. ठीक है, चलो. See, the more you start doing questions, no, the clarity of thought will become even more simpler. जितने आप क्वेश्चंस करोगे उतना आपका जो डाउट है वो एलिमिनेट होता रहेगा और उतना ही कॉन्सेप्ट कंसोलिडेट होता रहेगा. रीडिंग योर टेक्स्ट ओवर एंड अगेन इज डूइंग द सेम थिंग अगेन एंड अगेन एंड एक्सपेक्टिंग अ डिफरेंट रिजल्ट व्हिच इज नॉट गोइंग टू हैपन. वही चीज आप जो डेली करो वही दोबारा करते रहोगे तो आपका रिजल्ट भी वही होगा, चेंज नहीं होगा. So in order to change the result and the outcome, the path that you choose needs to be changed also. You need to pivot, you need to keep going again and again, है ना? So that is where your MCQs are very handy. Clear है? चलो, question number 23. So which of the following is not a boundary of your Passaro's triangle? Passaro's triangle is also called as Gastrinoma triangle. Also called as the Gastrinoma triangle. So if you look at the Gastrinoma triangle, take this as a representation of the esophagus. This is the stomach. This happens to be the duodenum. This is the first part of the duodenum. This is the second part. This is the third part. This is the fourth part of the duodenum. Take this as a representation of the liver. This is your left hepatic, right hepatic, common hepatic, cystic, gallbladder, and the common bile duct. Now this is your pancreas. This is the head of the pancreas, the neck and the body of the pancreas. So 3 points that I'm going to mark. The point number 1 is between the cystic duct and the common hepatic duct. The point number 2 is between the second and third part of the duodenum and the head and the neck of the pancreas. You draw a triangle here. This is what we call it as the Passaro's triangle. This is what we call it as the Passaro's triangle. So 3 points that we have drawn at the Passaro's triangle. Number 1 is the junction between the cystic duct and the common hepatic duct. And the common hepatic duct. The second is between the second and the third part of the duodenum. The junction between D2 and D3. And the third one is between the neck and the body of the pancreas. So this is junction. This is the most common site for gastrinoma. It's the most common site for the gastrinoma. Clear है? Clear guys? ठीक है? अब सवाल देख लो. सवाल क्या पूछ रहा है? Which is not a boundary. The junction between the cystic and the common bile duct, right? The junction between the cystic and the common bile duct, the junction between the second and third part of the duodenum, neck and the body of the pancreas. Body and the tail is wrong, no? Neck and the body, all three of them are correct. ये common bile duct, this duodenum and the pancreas. Common hepatic duct बोलो, common bile duct बोलो, दोनों का junction एक ही है. ठीक है? So answer here is going to be D for Delhi. It is going to be D for Delhi. Clear? Any doubts here? Any doubts? ठीक है, आंसर इज डी फॉर दिल्ली. अच्छा, एक मैक्सिमम क्वेश्चन दैट विल आस्क यू इन गैस्ट्रोनोमा. लेट्स क्विक रिकैप दैट आल्सो. What is the other name for gastrinoma? The gastrinoma is also popularly referred to as the Zollinger-Ellison syndrome. This is also called as the Zollinger-Ellison syndrome. Now, in the Zollinger-Ellison syndrome, how do you categorize it, or how do you know the patient is having a Zollinger-Ellison syndrome? The first one is your fasting serum gastrin. We'll measure the fasting serum gastrin. कोई मुझे बताएगा कितना होना चाहिए? What should be the range of the fasting serum gastrin to call it as gastrinoma? Quick feedback. क्या होना चाहिए? It should be more than 1000 picograms per milliliter, right? ठीक है? Just to give you an objective, what is the normal fasting serum gastrin? It is less than 100 picograms per milliliter. If you have such high serum gastrin levels, this is only possible in gastrinoma. This is only possible in gastrinoma. ठीक है? Clear है? Clear? ठीक है? एक और एडिशनली अगर आपसे पूछ लेगा pH कितना होना चाहिए स्टमक का, it should be less than 2, but that is not very specific, but this is what you have to remember. Clear? ठीक है? Also, the gastrinoma is also associated with Men syndrome. They are associated with Men 1 syndrome. They are associated with Men 1 syndrome. If I say what is the overall most common site for gastrinoma, the answer is duodenum. Now, whenever you have ulcer at D2, ulcer at the second part of the duodenum, it is suspicious of gastrinoma. Ulcer at D1 is your peptic ulcer disease. लेकिन अगर ulcer at D2 है ना, then you should think in terms of gastrinoma. In terms of gastrinoma. अच्छा, what is the investigation of choice to localize? What is the investigation of choice to localize gastrinoma? What is the investigation of choice to localize gastrinoma? Quick feedback. फटाफट बताओ। It is your 68 gadolinium dotatate PET. सिक्सटी एट गैडोलिनियम डोटाटेट पेट सीटी, ठीक है, तो पेट सीटी करके याद रख लो, वो भी बहुत इंपॉर्टेंट, ठीक। सो दिस इज विद रिस्पेक्ट टू गैस्ट्रिनोमा। एक और क्वेश्चन होगा आगे गैस्ट्रिनोमा के, इसलिए आई वांटेड टू कवर अप हियर। सो दिस इज विद रिस्पेक्ट टू गैस्ट्रिनोमा। क्लियर है? क्लियर? बेटा अगर डिओडिनम में है तो एंडोस्कोपी है ना, अगर अगर पैनक्रियास में है तो एंडोस्कोपी नहीं बता पाएगा। जंक्शन ऑफ योर सिस्टिक डक्ट और कॉमन हेपेटिक डक्ट या कॉमन बाइल डक्ट, वहां पे नहीं बता पाएगा, तो डोटाटाइट इज द बेस्ट वन। एंडोस्कोपिकली यू कैन लुक इट इन द डिओडिनम। ठीक है, चलो कितने क्वेश्चन हो गए? क्वेश्चन नंबर 23, क्वेश्चन नंबर 24। In question number 24, I have a 45-year-old man presents with surgery outpatient department. Complains of cachexia, weight loss is there, bloating and vomiting. On endoscopy examiner, tumor is found and was evading the subserosa without any lymph node involvement and distant metastasis. According to the TNM staging, what stage of gastric carcinoma? This was a bouncer, है ना। तो गैस्ट्रिक कार्सिनोमा के लिए सिंप्लीफाइड मैंने आपके लिए ऑलरेडी बना के रखा हो यहाँ पे। Now, if a tumor involves only the mucosal surface, that is epithelial surface, it is TIS. If it involves the muscularis proper, it is T1A. If it involves the submucosa, T1B, muscles is T2, subserosa is T3, invade serosa is T4A, and if the adjacent organ is involved, T4B. So subserosal है, तो subserosal है तो T3 हो गया, है ना? So here we have subserosal. It's a T3 disease, no lymph nodes. So there is no evidence of lymph node N0. There is no evidence of metastasis. Then it is going to be M0. So T3, N0, M0 will fall into which stage? T3, N0, M0 will fall into which stage? Remember, an easy way to remember. T1, N0, M0 is 1A, T2, N0, M0 is 1B, T3, N0, M0 is 2A. हमारा जो डिजीज अभी वो T3, N0, M0, T4A, N0, M0 will become 2B. So 1A, 1B, 2A, 2B. So T1, T2, T3, T4 इतना ही है, तो T3 में क्या हो जाएगा? It is going to be 2A disease. So T3 is going to be, so we say T1 गैस्ट्रिक कार्सिनोमा, जैसे मैंने कार्सिनोमा स्टमक के लिए बताया वैसे T1 N0 M0 is 1A, T2 N0 M0 is going to be 1B, T3 N0 M0 is going to be 2A, and T4 N0 M0 is going to be your 2B. It is going to be 2B. हमारा जो क्वेश्चन है T3 N0 M0 का है, that is going to be 2A disease, and this is your 2A disease. Remember this, that is more than enough. Chill है, ठीक है? Clear? चलो. If they ask you what is the most common route of spread for carcinoma stomach, it is hematogenous. Most common site for secondaries is liver, and the minimum number of lymph nodes were required to be calling as an adequate staging. For carcinoma stomach, it is 16, esophageal 15, colorectal 12, and breast cancer 10. This is decreasing order to be remembered. Gastric carcinoma के लिए the minimum is 16, esophageal 15, colorectal 12, breast cancer is going to be 10. कौन कौन सा TNM याद रखना है? TNM जो याद रखना है, क्विक फीडबैक ले लो। TNM जो याद रखोगे, TNM मैं ऑर्डर में लिख लेता हूं, जो सबसे इंपॉर्टेंट से लीस्ट इंपॉर्टेंट। सबसे इंपॉर्टेंट ब्रेस्ट कैंसर, थायराइड कैंसर, कोलोरेक्टल कैंसर, गॉल ब्लैडर कार्सिनोमा, गॉल ब्लैडर कैंसर, देन कार्सिनोमा स्टमक, कैंसर इसोफेगस, कैंसर इसोफेगस, ओरल कैंसर, एंड द लास्ट वन इज आरसीसी। ये सीक्वेंस है जिसमें याद रखना। सबसे इंपॉर्टेंट आपका ब्रेस्ट कैंसर है, लीस्ट इंपॉर्टेंट, आई मीन लीस्ट नहीं, मतलब ऑन द एंटायर पूरे जनरल सर्जरी में ये 8 TNM आपको याद रखने हैं। ठीक बेटा, यूजुअली स्टेजिंग पे सिर्फ ब्रेस्ट कैंसर पे आएगा। इफ दे आस्क यू द क्वेश्चन ऑन स्टेजिंग, नॉट ओनली TNM, स्टेजिंग आपको ब्रेस्ट कैंसर की याद रखनी है, बाकी स्टेजिंग आप भूल जाओ, नो नीड टू वरी अबाउट इट। ठीक है, चलो Going to question number 25. Looking at the image only, you would have gotten the eye diagnosis. I have a 5-year-old child with the history of appendectomy brought to the emergency room with vomiting and abdominal distension. Okay. The child reportedly passed feces with red currant jelly stools. Okay. According to mother, the ultrasound results is displayed below. So when you have dynamic obstruction, with red currant jelly stool, and if this is a child, if it is a child, the first diagnosis that you should think about is intersusception. And in children, remember the most common site. The most common site in children for intersusception is ileocolic. And the most common site in adult, it is colocolic. So here they're asking what is the most common site is ileocolic. So answer is going to be D for Delhi. Colocolic is going to be for adults. Now this is where you see there are two signs that you've seen. This is what we call it as the target sign, and this is what we call it as the pseudo kidney sign. This is your pseudo kidney sign, and this happens to be your target sign. Your pseudo kidney sign and the target sign. Okay. So the question number 25. So question number 26. A 28-year-old male presents to the casualty with high fever and pain in the abdomen. Okay. Had a history of bloody diarrhea for several months. Okay. His past history was negative for long-term medication and previous surgery. The abdominal X-ray image is obtained as given below. What would be the most probable diagnosis? Now, what you can see here, there's a massive distended large ball. So, massive distended large ball with the history of diarrhea, right? Now, such conditions are associated. When you talk about volvulus, no. If a patient has volvulus, then there will be colicky abdominal pain. There will be colicky abdominal pain with obstipation. That is absolutely no passage of stools and flatus. And on an X-ray, I will see a coffee bean sign. X-ray में मुझे coffee bean sign मिलेगा. Right? Here the patient is having diarrhea, so it cannot be volvulus. Oglev syndrome जो है, it is the other name for pseudo obstruction. It is an pseudo obstruction. Now here patient will not have history of diarrhea. ठीक है? For pneumatosis, that is pneumatosis intestinalis, there should be serpent sign on. That is, there should be a serpent sign on X-ray. So you'll see the air trapped in the wall. They'll look like a snake that is not there. So I can rule out this. So this is your toxic megacolon. Remember, if the transverse colon diameter is more than 6 centimeters, this is what we call it as toxic megacolon. So answer here is A for Ahmedabad. A for Ahmedabad. Okay. Such massive distended. History of diarrhea with all these features and distended bowel, it is going to be toxic megacolon. Okay. So far any doubts? So far any doubts? Quick feedback. ठीक है. चलो. So question number 26, going to question number 27. In question number 27, I have a 55-year-old man brought to the casualty with history of fever and abdominal pain. ठीक है. The pain was initially in the left lower quadrant for 2 days, then it became diffuse, severe for past 4 hours. ठीक है. Then we got an erect X-ray done. The erect X-ray of the chest revealed the presence of pneumoperitoneum. ठीक है, perforation हो गया. Emergency laparotomy was conducted. ठीक है. Showed the presence of perforated left-sided diverticulitis with fecal peritonitis. How will you manage the patient? How will you manage the patient? तो ये जो case है ना, this is a classical case of diverticulitis. ठीक है. This I would have told you multiple times in the class कि अगर पेशेंट को diverticulitis है, if there's a patient is having diverticulitis, the investigation of choice for diverticulitis is going to be CCT. Now, based upon the CCT, we have a classification which is called as the Hinchey's classification. Now, based upon the Hinchey's classification, you have the management. है ना? Right. So, what is this? According to the Hinchey's classification, grade 0 is only colonic wall thickening. Grade 1A is phlegmon with pericolonic fat stranding. 1B is pericolonic abscess. 2 is pelvic abscess. 3 is purulent peritonitis. 4 is fecal peritonitis. So here the patient is having what? There is showed a presence of perforated left side diverticulitis with fecal peritonitis. Agar fecal peritonitis hai, the patient is having stage 4 or a grade 4 Hinchey's. ठीक है. Fecal peritonitis is grade 4. How do you manage grade 4? I've given you clearly. For grade 1, 0, 1A, 1B, 2, it is going to be conservative. 3 and 4, it is going to be, which is with this peritoneum, exploratory laparotomy, do a Hartmann surgery, that's a temporary colostomy. This is what you will follow for your Hinchey's classification. Very clear-cut objective. We've discussed this in class also. तो यहाँ पे क्या करोगे? Okay, how will you manage? I will do saline irrigation. Yes, हाँ जी, हम करेंगे क्योंकि मुझे fecal resection करना है. I will do resection. Yes. Will I do an anastomosis? No. Will I do an end colostomy? Yes. Temporary करूंगा. Pigtail insertion, I will not do it. Pigtail insertion, that is only for grade 0, 1A, 1B and grade 2. ठीक है. So यहाँ पे क्या क्या करूंगा? I will do 1, I will do 2, I will do and 4 I will do. ठीक है. अच्छा. I've given if the combination only of 2. So I'll do 1 and 4 is the better one. I will do saline irrigation with end colostomy. 1 and 4. So I'll take out the 2 also. 1 and 4 is a better option. We don't have 1 and 4. 1 and 2 hai, 1 and 5 hai, 2 and 4 hai. Okay, 1 and 2 kya? Saline irrigation and resection. Yes, that can be done. ठीक है. 1 and 5 I will not do. 2 and 4 resection and end colostomy. See, without doing saline irrigation, how would you clear it? But resection and end colostomy will not do a resection, will do an end colostomy. Okay, so resection of sigmoid colon has to be done. That is also there. So 2 and 4 is also not a wrong option. 2, 3 is wrong. Anastomosis cannot be done. Okay, so I know that option B and option D is gone. I have to choose between 1 and C. Saline irrigation with resection or resection with end colostomy. Which one do you think is more defining the procedure? Out of 1 and A और C में से कौन सा ज्यादा better describe कर रहा है procedure को? I've already told you ये procedure अपना. Do an exploratory laparotomy, do a Hartmann's procedure which is a temporary colostomy. ठीक है? So this is what is describing our procedure. अब आप मुझे बताओ option में से which is better describing our procedure? Which option is better describing our procedure? बेटा resect कर रहे हो, colostomy कहाँ कर रहे हो? Colostomy is better, no? अरे यार, irrigate और resect कर रहे हो, colostomy तो बता ही नहीं रहे हो आप. क्या मालूम उसका anastomose कर दो, है ना? If you're going with option 1, that is 1 and 2 irrigation and resection, but I might think you are doing resection and anastomosis or resection और colostomy, confusion है. लेकिन अगर मैं बोल रहा हूँ 2 and 4 resect और colostomy कर रहा हूँ, ठीक है, resect और colostomy कर रहा हूँ, that gives me a better option, no? वो मुझे clear indication दे रहा है. Is that not clear? But a resection can also lead to anastomosis, not always colostomy. Correct? No. ठीक है? हाँ. So here answer is going to be C for Calcutta. Good question. It tested your common sense rather than your crude knowledge. Sort है सबके लिए? Clear है? चलो. Question number 28. In question number 28, a 10-year-old boy presented with abdominal pain and vomiting. There is pain on internal rotation of the right thigh and tenderness. Now, the minute you say pain, right iliac fossa pain. Right iliac fossa pain with increase in pain on internal rotation of the hip. Is what we call it as psoas sign positive. Is what we call it as the psoas sign positive. and psoas sign will be positive if the appendix is in retrocecal position. If the appendix is in the retrocecal position, right? Now you have, okay, and noted in the pouch or Douglas on rectal examination. What is the most likely position of the appendix in this patient? So as I told you, if psoas sign is positive, it is clear cut, it is going to be in retrocecal. Now I've given you a few important points to remember. अगर पेशेंट का अपेंडिक्स रेट्रोसीकल है, there will be positive psoas sign, pain on passive extension of the right hip. ठीक है. अगर if it is pelvic position, remember the patient is going to have operator sign positive, pain on internal rotation and flexed right hip. ठीक है. And also painful digital rectal examination. I've written ulta there. Sorry. It is not psoas. देखो right iliac fossa pain with internal rotation of hip is not psoas sign positive. It is pelvic sign positive. Sorry guys. Make a small correction. उल्टा लिख दिया. राइट iliac fossa में पेन है, इंक्रीज पेन ऑन इंटरनल रोटेशन, इट इंडिकेट्स पेल्विक पोजीशन. Remember here the increase in pain is on digital rectal examination and hip internal rotation. Sorry. psoas sign में extension क्योंकि psoas muscle gets irritated on extension. ठीक है, sorry. So here it is not retrocecal beta, it is going to be pelvic. It is going to be pelvic. Small correction, sorry. ठीक है. अगर रेट्रोसीकल है तो पेन ऑन द पैसिव एक्सटेंशन ऑफ द हिप मिलेगा. ठीक है. अगर पेल्विक है वी विल गेट ऑपरेटर साइन पॉजिटिव. सो दिस इज योर ऑपरेटर साइन पॉजिटिव जस्ट बिफोर यू फॉरगेट इट. दिस इज योर ऑप्टूरेटर साइन पॉजिटिव, है ना. अगर सबसीकल होगा, subcecal you will have peritoneal sign with the maximum tenderness and McBurney's point. Pre-ileal or post-ileal patient is going to have irritation of the ileum causing diarrhea. Subhepatic होगा तो cholecystitis like features होंगे. ठीक है. So do remember this. Retrocecal psoas sign positive, pelvic operator sign, subcecal severe peritonitis, pre-ileal post-ileal diarrhea and subhepatic is going to be cholecystitis. ठीक है. Most common retrocecal position beta, correct. Retrocecal is the overall most common position. I've given you prevalence of the most common is going to be retrocecal and pelvic is 30%. Most common is retrocecal followed by your pelvic position. ठीक है. Beta it is on the based on the position of the appendix. ठीक है. Just quickly देख लेते हैं. Now if you say this is the ascending colon, this is the cecum, this is the terminal ileum that you have. Now usually when you talk about the appendix, it is in the retrocecal position. ठीक है. तो अगर retrocecal appendix will go like this and you see it is going to be behind the cecum. So this position of the appendix is retrocecal. ठीक है. अब retrocecal there is a muscle which is going to be present, that is a psoas muscle. There is a muscle that is present in the retrocecal region, that is going to be a psoas muscle. ठीक है. So when the appendicitis occurs, it can irritate the psoas muscle also. The psoas muscle will get irritated. The psoas muscle will get irritated if there is a retrocecal appendix causing appendicitis. It is your retrocecal appendix. So whenever the patient will extend the hip, on extension of the hip, the psoas muscle has to stretch and the psoas muscle is already irritated, it will cause pain. So that is called as the psoas sign positive. So retrocecal appendix में psoas sign positive मिलेगा. ठीक है. अच्छा. दूसरा अगर appendix is pointing towards the pelvis, if the appendix is pointing towards the pelvis, this is called as the pelvic appendix. If it is pointing towards the pelvis, then you have operator sign positive. Now because it is going to irritate the operator nerve, है ना? So what is going to happen whenever there is an internal rotation? This Hauschipp-Romberg sign. अच्छा ये बताओ, where do you see Hauschipp-Romberg sign? Quick feedback. Hauschipp-Romberg sign कहाँ पे देखोगे? Where would you see Hauschipp-Romberg sign? The house-shaped rhombic sign is seen in obturator hernia. Same thing, no? Internal rotation of the hip, we flex the hip, rotate internally, you'll get pain along the obturator nerve, shooting pain, that is the obturator hernia. Same way, this inflamed appendix will now irritate the obturator nerve, which is causing the same component, है ना? And then it will also cause tenderness in the pouch of Douglas, which is appreciated on a distal rectal examination. अगर pre-ileal या post-ileal होगा, if the appendix is going to be pre-ileal, which is here, there's a pre-ileal or a post-ileal, it will irritate the ileum. ठीक है, pre-ileal or post-ileal, this is your pre-ileal or post-ileal position. They will irritate the ileum and that will present to you as diarrhea. That will present to you as diarrhea. That will present to you as diarrhea. ठीक है, clear है? So this is on the basis of their position. ठीक है, चलो, can you move on? So that's our question number 28. Question number 29. This is a spotter. Okay, what do you see? Our 12-year-old child with the symptoms of intestinal obstruction brought to the emergency room. A target sign is seen on ultrasound. Target sign on ultrasound का मतलब क्या है? Target sign on ultrasound with obstruction. With dynamic bowel obstruction. With dynamic bowel obstruction, the diagnosis has to be intussusception. It has to be intussusception. So, पहला तो one we have got to know that the baby or a patient is having intussusception. That is 12-year-old, no? ठीक है. Now, suggested intussusception already दे दिया. The palms and the oral mucosa both exhibit numerous 1 to 2 millimeters blue-gray macules. So, there is pigmentation. So, intussusception के साथ आया. And then they also have mucocutaneous pigmentation. They also have mucocutaneous pigmentation. Now, for intussusception to occur, there has to be a lead point. So, here it is secondary to polyps, right? So, polyps in the small intestine, that is in the jejunum, obviously, है ना? So, what is this condition? This is your Peutz-Jeghers syndrome. This is a Peutz-Jeghers syndrome. In Peutz-Jeghers syndrome, your mucocutaneous pigmentation is there with hamartomatous polyps in the jejunum that can lead to intussusception. Okay, that can lead to intussusception. So answer here is Peutz-Jeghers syndrome. देखो Lynch syndrome जो है वो hereditary non-polyposis colorectal cancer है. So here they will not have polyps only. Now Turcot syndrome क्या है? Turcot syndrome is FAP with brain tumors. And they are seen in age above 40 years. Whereas the polyps in your Peutz-Jeghers syndrome, the hamartomatous polyps, the juvenile polyps, they're seen in age between 12 to 14 years, classical of this. Cowden's disease is associated with colorectal cancer. It is a P10 gene mutation. Associated with colon cancer. Okay. So this is not going to be in your spectrum of the disease. Here the answer is Peutz-Jeghers syndrome. Okay. Clear? Turcot syndrome is FAP with brain tumors, beta. FAP with brain tumors, that is familial adenomatous polyposis. Brain tumor is what we call it as the Turcot syndrome. Clear hai? Chal. Question number 30. A patient complains of serous discharge coming from the perineal region. Okay. On examination, the external opening was noted at 8 o'clock. All right. According to Goodsall's rule, what is the position related to the dentate line in the internal opening of this is located? Now, what is a Goodsall's rule? Goodsall says that keep the patient in the lithotomy position, right? Keep the patient in a lithotomy position. Let's say this is how I am depicting the patient in a lithotomy position. This is the anal opening. This is the anal opening. Now, draw the line that goes dead in the center of the anal opening. Divide the perineal region into anterior and the posterior half. If the opening is present in the anterior half, it is going to be straight. And if it is present in the posterior half, it is going to have a curved tract. It is going to be curved tract. This is what your Goodsall's rule is. Okay. This is what your Goodsall's rule is trying to tell you, that if the opening is present in the anterior half, it will have a straight tract, and if it is opening in the posterior half, it will have a curved tract. ठीक है. Now it says the external opening was noted at 8 o'clock position. ठीक है. According 8 o'clock position का मतलब क्या हो जाएगा? Let's understand that also. This is 12 o'clock. This is 6 o'clock. This is 3 o'clock. This is 9 o'clock. So when I say 8 o'clock will be in the posterior half. Now, because 8 o'clock position is in the posterior half, it will have a curved tract. That means it will never open at 8 o'clock, right? That means if you have an opening at the 8 o'clock, if the opening is present at the 8 o'clock, this will have a curved tract. So the internal opening can be at 6 o'clock, can be at 7 o'clock, somewhere else, but not at 8 o'clock. That is what we're trying to tell you. है ना? अच्छा. So relative to that, at what position related to dentine line internal opening is most likely to locate? Remember, with respect to this, it won't open at 8 o'clock. I can strike off 8 o'clock. It won't go to anterior. So anterior क्या है? Anterior is going to be 1 o'clock. 1 o'clock is anterior. It is not happening. ठीक है? 4 o'clock is on the other side. So other side will also not happen. So most likely it is going to go down onto 6 o'clock. ठीक है? It will stay in the same quadrant. So 4 o'clock is here. तो ये ऐसे करके पूरा घूम के नहीं जाएगा. ठीक है? So answer here is going to be 6 o'clock. आई बात समझे? Clear है? Again, very beautiful interpretation of Goodsall's rule. Those who could not comprehend, फिर से बताता हूँ Goodsall's rule का ऑब्जेक्टिव क्या है. Goodsall बोलता है कि if you take this a lithotomy position, take this a representation of anal opening. ठीक है? Okay. And we'll say this is the midline that is present, dividing that into anterior and the posterior half. ठीक है? अच्छा. Goodsall has a very easy way of projecting things. It says that imagine the whole objective is in a form of a clock. This is 12 o'clock, this is 6 o'clock, this is 3 o'clock, this is 9 o'clock. It says if the opening is present in the anterior half. ठीक है? अगर opening 1 o'clock पे है तो internal opening भी 1 o'clock पे होगी. अगर opening 2 o'clock पे है, internal opening भी 2 o'clock पे होगी. अगर opening 3 o'clock पे है तो internal opening भी 3 o'clock पे होगी. अगर opening 12 o'clock पे है, internal opening 12 पे होगी. अगर 11 o'clock पे है, 11 पे होगी. अगर 10 o'clock पे है तो opening of internal is also going to 10. अगर 9 o'clock पे है तो भी 9 पे ही होगी. ठीक है? So in the anterior opening, whatever the opening is, and then the outer surface, the inner opening will also be in the same position because they are going to be in the same position, that is in the anterior half. लेकिन अगर opening posterior half में है, now in the posterior half, I can say that this is again 12 o'clock, this is 6 o'clock, this is 3 o'clock, this is 9 o'clock. ठीक है? अच्छा. If the opening is present at 4 o'clock, ठीक है? This is at 4 o'clock. It will never open at 4. It will always open somewhere here, or it can open somewhere here. That is, it can open at 5 o'clock, it can open at 6 o'clock position, but not at, we say it is, let's say, if the opening is at the 4 o'clock position. If the opening is at 4 o'clock position, I'll just change it across. Let's say the outer opening is at the 4 o'clock position. The inner opening can never be at 4. It will either be at 5 o'clock or it will either be at 6 o'clock, but never at 4 o'clock. Okay. Same way, if the opening is present at the 7 o'clock position, either it will open at 6 o'clock position or it will open at 8 o'clock position, but never at 7 o'clock position. That is your curved one. That is what your Goodsall rule is always trying to tell you. ठीक है? ये आपका Goodsall rules का ऑब्जेक्टिव है. I hope the interpretation is clear. ठीक है? चल. That's a question number 30. Going into question number 31. We have a 28-year-old male present with 4 into 4 umbilical swelling. Okay. Surgery was performed. The mesh was placed in the described location. Okay. Placing the mesh under the rectus muscle, underneath the rectus muscle and above the posterior rectus sheath is known as. ये जो क्वेश्चन है ना, ये आप गांठ बांध लो, इस साल भी एक क्वेश्चन इस स्पेक्ट्रम से आएगा. ठीक है? क्या है ये? पहले तो देख लेते हैं कि मेश की प्लेसमेंट कहां कहां पे है. तो just to give a quick recap of what we have with us, this is the orientation of the abdominal wall, this is the skin, Then you have the subcutaneous fatty layer. ठीक है. This is your external oblique muscle, the internal oblique muscle, the transverse abdominis muscle, ठीक है. Then you see this is your fascia transversalis, and there will be one more layer which is going to be here. The last layer that you'll see is going to be peritoneal. The last layer that you see is going to be peritoneal. ठीक है. अच्छा. If the mesh is placed, this is the first position. If the mesh is placed under the subcutaneous fat above the anterior rectus sheath. So आगे, just to give you an objective, this is your rectus abdominis muscle. This is your rectus abdominis muscle. Above the rectus abdominis muscle, this is your anterior rectus sheath. This is your anterior rectus sheath. And this happens to be your posterior rectus sheath. This happens to be your posterior rectus sheath. ठीक है. अच्छा. If you're placing a mesh under the subcutaneous fat above the anterior rectus sheath, this is what we call as onlay. This is called as onlay mesh repair. If it is between the two rectus abdominis muscle, which is here, this is what we call it as inlay. Now, if it is between the rectus abdominis muscle and the posterior rectus sheath, this is what we call it as retrorectus. This is called as retrorectus. If it is on the undersurface of the posterior rectus sheath above the fascia transversalis, it is called as sublay. If it is above the peritoneum, this is what we call it as IPOM. IPOM is intraperitoneal. It is intraperitoneal onlay mesh repair. It is your intraperitoneal onlay mesh repair. It is your intraperitoneal onlay mesh repair. Every single time they've asked you the exam, this is what they have asked you. ठीक है. Clear? अच्छा. अब सवाल क्या पूछ रहा है? वो बोल रहा है कि between the rectus muscle and the posterior rectus, it is retrorectus. ठीक है. So ये onlay तो नहीं है. It cannot be onlay. ठीक है. Onlay is under the subcutaneous fat. Sublay क्या है? Right? What is sublay? It is behind the your posterior rectus sheath. It is inlay is between, ये भी नहीं है. So the only option left is underlay. Underlay is also called as retrorectus. Retrorectus बोल लो या underlay बोल लो, एक ही बात. Retrorectus or also called as underlay. ठीक है. सो आंसर हियर इज, बेटा इनले नहीं होगा ना यार. इनले तो दो रेक्टस एब्डोमिनस के बीच का है, ये इनले है. ठीक है. चलो. The other one is your triangle of doom, triangle of pain, corona mortis. जल्दी से देख लें. Triangle of doom का medial border क्या होगा? Triangle of doom का जो medial border है, that is going to be vas deferens. Lateral border is going to be your gonadal vessels. Inferiorly by peritoneum. Apex is formed by the deep inguinal ring. The content is going to be your external iliac artery and the external iliac vein. Triangle of pain, medially it is going to be gonadal vessel, laterally is going to be iliopubic tract. Inferiorly by peritoneum. Apex is formed by deep inguinal ring. Corona mortis is because of abnormal obturator or aberrant. Is an aberrant obturator artery. It is an aberrant obturator artery. ठीक है. So these are three important: triangle of doom, triangle of pain, and the corona mortis. चलो, great. Can you move on? So far any doubts? ये question important था बेटा. Quick feedback. So, question number 32. This we have already discussed it. Suturing rule में already देख लिया था ना. What should be the ideal length of the suture material to suture the wound? It should be 4 times the length of the wound. 4 times the length of the wound. That is going to be 4:1. Answer is C for Calcutta. Question number 33. The minute you see this, no, this is called as the snake skin appearance of gastric mucosa. Now, on an upper GI endoscopy, if you see this mosaic pattern of gastric mucosa, the diagnosis is going to be portal hypertensive gastropathy. This is secondary to portal hypertensive gastropathy. It's a portal hypertensive gastropathy. Now let's look at the question. What does the question says? Question says, on an upper GI endoscopy performed elderly patient who had chronic black tarry stool, that means melena is there. Gastric mucosa was visualized as seen below. What is the most likely diagnosis? I've already given you the spotter. But this is how you diagnose it. It is your portal hypertensive gastropathy. Watermelon stomach is seen in gastric antral vascular ectasia. So ये तो antrum में you'll see alternate stripes. That is a watermelon. Meniere's disease is hypertrophied mucosal folds. It is a hypertrophied mucosal folds. Meniere's disease is also called as hypoproteinemic gastropathy. Also called as hypoproteinemic gastropathy. Delafoy's gastric lesion will present to you with upper GI bleed. It will present to you as an upper GI bleed. This is an abnormal arteriole. It is an abnormal arteriole, and this is seen on high on lesser curvature. It is seen high on lesser curvature. Okay? This is a Delafoy's gastric lesion. Answer is portal hypertensive gastropathy. Question number 34. I have a 2-year-old boy presents to the emergency room with petechiae, bruising, abdominal distension as shown. Okay? Investigation reveals that an elevated D-dimer level and thrombocytopenia. CCT of the abdomen shows a solitary hepatic lesion with peripheral nodular enhancement. Hepatic lesion with peripheral nodular enhancement. 2 साल का बच्चा है, petechiae purpura है, abdominal distension है, D-dimer elevated है, thrombocytopenia is there. ठीक है? Which of the following statement regarding this condition is incorrect? Okay. Now, what is the diagnosis first? What is the diagnosis that you have? What is the diagnosis? 2 साल का बच्चा, petechiae is there, bruising is there, D-dimer is there, thrombocytopenia is there. ठीक है? CCT says there is solitary hepatic lesion with peripheral nodular enhancement. With peripheral nodular enhancement, which is also like a light bulb appearance, है ना? Clear? Quick feedback. Quick feedback. Quick feedback. Waiting for your response, guys. Quick feedback. Refreshing the chat box also. Quick feedback. बेटा इट इज नॉट HCC यार. बच्चे 2 साल के बच्चे में HCC होगा, या तो हेपाटोब्लास्टोमा होगा या फिर हेमांजियोमा ऑफ द फोक. देखो हेमांजियोमा, when you look at the hemangioma of the liver, देखो hemangioma of liver जो है that will have peripheral nodular enhancement. ठीक है? Hemangioma of the liver, that is the whole pickup. There's a peripheral nodular enhancement. अच्छा, इससे important क्या है? In a giant hemangioma, whenever you have a patient with giant hemangioma are those hemangiomas which are more than 5 centimeters in diameter. If it is more than 5 centimeter in diameter, it is a giant hemangioma, and giant hemangioma is associated with Kasabach-Merritt syndrome. It is associated with Kasabach-Merritt syndrome. And Kasabach-Merritt syndrome, what is the patient is going to have? In Kasabach-Merritt syndrome, the patient is, number one, they're going, see, in a Kasabach-Merritt syndrome, there is platelet trapping, because there will be thrombocytopenia. Thrombocytopenia and coagulopathy. That coagulopathy will present as petechiae purpura, right? And thrombocytopenia is evident. Now, remember, whenever there's a Kasabach-Merritt syndrome, it's a giant hemangioma, you have to go ahead with hepatic resection. Okay? Along with hepatic resection, when you have to reconstruct, you might have to do the management here for giant hemangioma is going to be enucleation. It is a enucleation. ठीक है? अच्छा, अब आ जाओ यहाँ पे. They're asking for incorrect. In symptomatic, देखो Kasai's, अच्छा, या पहले ही the answer is already sorted. What is Kasai's procedure? Kasai's surgery is portoenteric anastomosis. It is a portoenteric anastomosis. Now, portoenteric anastomosis or the Kasai's procedure is done for extrahepatic biliary atresia. It is done for extrahepatic biliary atresia. It is associated or done for extrahepatic biliary atresia. तो ये extrahepatic biliary atresia तो है ही नहीं. तो if it is not there, I will not do Kasai's procedure. So this is gone. Small lesions less than 5 centimeters are regress spontaneously. Tumor markers, see, LFT tumor markers will be absolutely normal. There is no problem. And congestive heart failure can occur because of coagulopathy is correct. So answer here is going to be A for Ahmedabad. So the whole trick is to diagnose this as Kasabach-Merritt syndrome. It's a Kasabach-Merritt syndrome. Okay? Chalo. That's a question number 34. Good question, good implication, nice. Question number 35. A surgeon with a limited experience in laparoscopic cholecystectomy discovers stones in the CBD during the laparoscopic surgery. Okay, what should be the ideal course? See, when a surgeon does not, common sense, no, a surgeon is not confident in doing lap, convert into open and do it off. No, so laparoscopic exploration CBD and remove, because he's not confident in lap, right? He has limited experience. I would not recommend him to explore it. Open cholecystectomy, open choledochoduodenostomy is correct. Convert into, convert into open cholecystectomy, remove CBD stone. This is better. Laparoscopic CBD extraction, I will not do it. Open cholecystectomy with choledochoid, I don't know do choledochoduodenostomy. I'll do CBD stone removal. The answer is C for Calcutta. Simple context. Okay. Question number 36. Achha, what is the most effective way to localize an insulinoma? This is repeatedly asked. It is an endo ultrasound with manual palpation during the surgery. That is going to be EUS. MRI, SRS and PET-CT won't help it. It is endoscopic ultrasound with intraoperative palpation is the best method to localize insulinoma. Remember, insulinoma is associated with Whipple's triad. It is associated with the Whipple's triad. Patient will have low blood, when you look at the blood sugars, is less than 50 grams per deciliter. Patient will have severe hypoglycemia. Symptoms, that is syncope will be there. And immediate reversal of symptom on giving glucose. Immediate reversal of symptoms on giving glucose. The surgery of choice. See, most of them, most commonly insulinomas are benign. Management for insulinoma is actually enucleation. Okay. So that are the important points with respect to for insulinoma. Clear? Chal. Going to question number 37. I want you to be a little bit active. We are just 13 questions away to finish it. Hold on, I know it is tiring. We have crossed 2 hours, but okay, fine. We'll give that concentration. Beta, you have to concentrate 3 hours straight in the exam. ठीक है? Option नहीं है. 2 papers हैं, 150 के. So you have to put 6 hours in total. So at least let's have that concentration going on. I don't want you to drop it down. ठीक है? 13 more questions. Let's finish it off. Which of the following statement is not true about Zollinger-Ellison syndrome? We have already discovered this is nothing but gastrinoma. This is nothing but gastrinoma. Right? Now, gastrin levels of more than 1000 is correct. Basal acid output is more than 15 milliequivalents per hour. Somatostatin receptor scintigraphy is not useful investigation. Omeprazole is helpful. Okay. Now, they're asking which of the following statement is not true. What do you think? A quick feedback. We've already discussed about gastrinoma. Quick feedback. Already discussed about gastrinoma. Fatafat batao. Basal acid output of more than 15 milliequivalents per hour is correct. Somatostatin receptors, SRS is, see, for all neuroendocrine tumors, for localization, SRS is the investigational choice. Somatostatin receptors scintigraphy study is the investigation of choice to localize all neuroendocrine tumors. So it's not useful is wrong. It is the investigation of choice to localize. Omeprazole is helpful. Yes, it decreases the symptoms. So answer here is C for Calcutta. Correct. Question number 38. Come on, guys. Question number 38. All of the given conditions are associated with acute pancreatitis except. Okay. What is Fox sign? What is Fox sign? It is seen as ecchymosis along inguinal ligament. Okay. So what is your Gray Turner sign? Gray Turner sign is ecchymosis along flank region. What is your Cullen sign? What is your Cullen sign? The Cullen sign, what is your Cullen sign? The Cullen sign is going to be ecchymosis in the periumbilical region. Ecchymosis in periumbilical region. Ecchymosis in periumbilical region. All of them indicates hemorrhagic pancreatitis. So whenever you have hemorrhagic pancreatitis, in hemorrhagic pancreatitis, or whenever there is a retroperitoneal hemorrhage, whenever there is a retroperitoneal hemorrhage, whenever there is a retroperitoneal hemorrhage, you will see these signs are going to be positive. Now, abdominal distension can also be there because of pancreatic ascites. Hematemesis is usually not seen in pancreatitis. Hematemesis is usually not seen. Steatoria is associated with chronic pancreatitis. It is associated with chronic pancreatitis. Okay? It is associated with chronic pancreatitis. Clear? See, hematemesis is not a very consistent finding, but if you say steatorrhea is with chronic pancreatitis, so answer here is going to D for Delhi. Clear है? Steatorrhea chronic में मिलेगा ना बेटा. देखो acute pancreatitis में sometimes it can have gastric erosions. ठीक है, especially the duodenal erosion because of the bulky head of the pancreas, and that can result in pancreatitis. Atlanta classification is to look for the prognosis. Ranson's is for the same criteria, so don't worry about it. ठीक है. Question number 39. Okay. Image is clear. This is the right kidney, this is the left kidney. I can see one ureter, two ureter. There's a duplication that is going on. Okay? This is the anomaly of duplication. You don't need to worry about it. What is the question? 1 month old child, recurrent urinary tract infection, dilated inner pelvis, IVP is done, and what is the likely diagnosis? For all patients of anomaly of duplication, they are associated with abnormal ureteric orifice. That is what we call as the Weygert-Meyer law. No, Weygert-Meyer law क्या बोलता है? What does the Weygert-Meyer law tells you? It is about the ectopic ureteric orifice. According to Weygert-Meyer law, if the ureter is arising from the upper pole, this is the bladder and the urethra. If it is arising from the upper pole, it is going to be more medial and more distal in opening. If it is arising from the lower pole, it is going to be more lateral and more proximal in opening. And this is what we call it as the Weygert-Meyer law. The Weygert-Meyer law is for ectopic ureteric orifice. It is for ectopic ureteric orifice. So here it is not a retrocaval. See, if you have a retrocaval ureter, you have fish hook ureter. On an IVP, you will get a fish hook ureter. It's a duplicated ureter. For polycystic kidney disease, you will have spider-leg appearance. And horseshoe kidney, you have flower vase appearance. So answer here is duplicated ureter. It's going to be duplicated ureter. Question number 40. Now, which of the following types of the renal stones are produced by laxative abuse? For laxative abuse, see, when I say struwite stones, these are phosphate stones. The phosphate stone is because of protease infection. It is because of protease infection, and this will result in staghorn calculi. It will result in staghorn calculi. It is also called as the silent stone. It is also referred as silent stone. It is also called as the triple stone. So it is not because of laxative. So I can strike out struwite. Uric acid stone is because of excessive production of uric acid. So that is secondary to gout. So it is seen in patients like gout. So again, it is not going to be associated with laxative. Ammonium urate is going to be with laxatives. Calcium oxalate is because of hypercalcemia. Hypercalcemia or hypercalciuria or hyperoxaluria. So answer here is ammonium urate. See, even if you don't know ammonium urate, the other three reasons or the causes, it is easy to diagnose it. Okay? So answer here is going to be C for Calcutta. Question number 41. Again, it's a straightforward question, easy one to remember. According to the Bosniak's classification, system, primary use for which condition? It is for renal cyst, incidentally found renal cyst, not for RCC. So Bosniak classification. Okay. Whatever the other जो भी अभी queries है ना, other than that of the subject, I'll address at the end of the class. अभी के लिए stick to the class. ठीक है? Okay. Bosniak classification, I hope everybody knows it. Do you want me to repeat Bosniak's classification? Quick feedback. फटाफट. Beta chat box need to buzz. 9 more questions to go. 9 more questions to go. That's it. Bus no question. And then we are done with today. सिंपल जल्दी कर दो बॉसनाइक क्लास में. चलो ठीक है, आपसे क्या ही पूछना, बता ही देते हैं. Bosniak classification, class 1 is a simple cyst. It is a simple cyst. It's a single cyst which is filled with fluid, no septation. Then you have type 2. Type 2 is minimally complex. How do you know it is minimally complex? You see there is a cyst that is present. There is only single septation and the fluid is filled. This is minimally complex. Then you have 2F, minimally complex requiring follow. F is follow-up. Minimally complex. Minimally complex requiring follow-up. Now, when do you call this? You have more than one septation. There's a multiple septations are there and there's filled up with fluid. This is your 2F. Then you have class 3. Class 3 is indeterminate. Now, indeterminate way, number one, you see the wall of the cyst is going to be unevenly thickened. There will be multiple septation. The septation is also thick wall septation. They have thick wall septation. They have fluid filled. So, how do you know it is indeterminate? It is a thick walled cyst with thick septas with calcification. It is indeterminate. 4 is going to be heterogeneous. If there is a heterogeneous one, we call it as a malignant cyst. 4 is malignant, where you have in the same lesion, there is a solid component and there is fluid filled also. So it is both solid and cystic. It is type 4. Now, according to Bosniak's classification, for 1 and 2, do nothing. For 2F, we'll ask the patient to come back after 6 months for ultrasound or CT. For 3, we do partial nephrectomy. For 4, we will perform nephrectomy. For 4, we are going to perform nephrectomy. So this is the entire course of action. Clear? So this is on the Bosniak's classification. Again, very important. Question number 42. I have an elderly man rushed to the casualty midnight complaining about suprapubic pain and inability to pass urine for past 24 hours. The abdominal examination find the patient is being given below. Okay. A smooth and enlarged prostate was felt. Okay. Smooth and enlarged prostate was felt in the prerectal examination. While attempting to insert a 16 French Foley's catheter, this patient, you feel resistance and failed to catheterize. What will be the next step? See, whenever there's a BPH patient, if you fail to catheterize, we have something called as a Cauday catheter. There's a curved tip catheter. You have to use that. So I will use a Cauday catheter. Yes. Insert a smaller size. I will not do a cystoscopy. I'll see, unless I don't attempt for the Cauday catheter, I'll always try to put a Cauday catheter. If it fails a Cauday catheter, then I will go with suprapubic cystostomy. So answer here is going to be A for Ahmedabad. It is going to be A for Ahmedabad. It's a curved tip catheter. It's a curved tip catheter. They're specially made for patients with BPH. They're specially made for the patients with BPH. Okay? Clear hai? Quick feedback. Clear hai? Can we move on? ठीक है? हाँ, निमोनिक याद रख लो, गोरी है, green, ठीक है, orange, red and yellow. That's the color code of the Foley's catheter. 14, 16, 18, 20 French. Same context. चलो. Question number 43. Now, child with recurrent urinary tract infection. ठीक है. undergoes avoiding cystourethrogram, okay, shows a reflux of urine into renal pelvis and the calyces without dilatation of ureters. What is the grade of VUR? Now, grade of VUR is very interesting and easy to remember. So, grade 1, grade 2, grade 3 and grade 4. If the reflux into ureters, it is called as grade 1. Grade 2, reflux into pelvic-calceal system, into the pelvic-calceal system with normal ureter. It is grade 2. Reflux into pelvic-calceal system with dilated ureter is grade 3. Reflux all the way to pelvic-calceal system with blunting ureter is grade 4. Then grade 5 is going to be reflux all the way to pelvic calcium system with tortuous. With the tortuous ureter. Okay. Now, based upon the explanation, you tell me what is the present scenario like. It says the reflux is into renal pelvis and the calces without dilatation into ureter. Without the ureter getting dilated, it is a grade 2. Answer is grade 2. It is a grade 2. Okay. Question number 44. Question number 44. Which of the following compounds form the endogenous prostatic calculi? It is, see, when you talk about prostatic calculi, it is nothing but a calcified prostate gland. And a calcified prostate gland will present to you with calcium phosphate. So, answer is calcium phosphate. Because struvite is infectious, uric acid is because of gout, calcium oxalate is hypercalcemia. It's a calcified component within the prostate gland. Answer is going to be calcium phosphate. It's a calcium phosphate. It's a calcium phosphate. Okay? Chalo. What is the other name for this? It is also called as corpora amylicia. This is also called as the corpora amylicia. Also called as corpora amylicia. Question number 45. All of the following are true about the superior mesenteric artery syndrome except. Quick recap कर लेते हैं SMA artery syndrome क्या है. When I talk about the SMA artery syndrome, when you talk about the superior mesenteric artery syndrome, देखो normally क्या होता है? You take representation of esophagus. This is the stomach. This is the duodenum that is present. This is the first part of the duodenum. This is the second part of the duodenum. This is the third part of the duodenum. And this is the fourth part of the duodenum. You see the superior mesenteric artery. Basically, it is arising from aorta. So, you take this as a representation of the aorta. This is how the aorta is traveling. Correct? The superior mesenteric artery is going to arise from the aorta and it goes over the D3. This is the origin of superior mesenteric artery and it goes over D3. And you see the takeoff angle. There is some amount of fat that is present. So, this fat between the superior mesenteric artery and the aorta will make the superior mesenteric artery to come at a certain angle. Okay? So, this is your superior mesenteric artery. This is the aorta. And there's a fat that is present between these two. Now, because of this fat, the normal takeoff angle is going to be more than 25 degrees. That is 25 to 45 degrees. This is the normal takeoff angle. What is the takeoff angle? That is the angle between the superior mesenteric artery. This. Between the superior mesenteric artery and the aorta. This angle is what we call it as takeoff angle. When will you have a superior mesenteric artery syndrome? SMA syndrome, if the takeoff angle is less than 20 degrees, it will cause superior mesenteric artery syndrome. Superior mesenteric artery syndrome will cause compression of D3 obstruction. The patient will present with D3 obstruction. This is your superior mesenteric artery syndrome. As simple as that. ठीक है? अच्छा, अब क्या बोल रहा है? The third part of the duodenum is compressed is true. The angle between the superior mesenteric artery, aorta and aorta is less. It is wrong. 25 to 45 degrees. Surgical management is by duodenojejunectomy. See, you can do a duodenojejunectomy also. Duodenojejunectomy. It is also known as the Wilkie syndrome. Correct. ठीक है? It is also known as the Wilkie. It is also called as spinal cast syndrome. It is also known as your what do you call it as Wilkie syndrome, SMA artery syndrome, also called as spinal cast syndrome. Okay. So all these three names of a superior eccentric artery, which of the following, all of the following are true except that is going to be B. The normal takeoff angle is between 25 to 45 degrees. Okay. Clear? B for Bombay. Question number 46. So far, any doubts, beta? Quick feedback. Quick feedback. So, looking at the question number 46. Which of the following is true regarding the management consideration the patient of submandibular gland stones, also called as the silolithiasis? Okay. Let's look at the statement. Which of the following is true? They are looking for a true statement. Okay. The surgical gland excision, is it? No, why would we excise a gland? No. We will do only removal of the stone by incising it. Associated chronic silentinitis is a contra. No, it is not a contraindication for silentectomy. It's wrong. Conventional radiograph is most. No, 80% of them are radio opaque. They're not radiolucent, they are radio opaque. So conventional radiographs are easy. So this is also wrong. Obviously, the answer will be yes. Stones proximal to lingual nerve can be removed by intraoral approach. Correct. And distal to that should be removed with a submandibular excision. Okay? Clear? But if you have done TND before also, this is like a quick rapid revision. Again, most of the topics are in the same coherence. It's a good revision for you. See where you're lacking, and that's the concentration that you need to keep. Nothing more than that. Question number 47. Looking at the image, I know it's a sublingual swelling. So this is your ranula. So what is a ranula? It is an extravasation cyst. It's the extravasation cyst of sublingual gland. Of the sublingual gland. Okay. So this is what we call it as ranula. Ranula is nothing but extravasation cyst of the sublingual gland. If there's a plunging ranula, that is a retention cyst. ये extravasation, a plunging ranula, अगर swelling in the undersurface of the tongue and then it is also projecting into the neck region, it's a plunging ranula. Plunging ranula क्या होगा? It will be a retention cyst. ये extravasation cyst है. Acha. The question says, I have a 5-year-old boy brought to the OPD by parents of okay, there's a painless, soft, translucent swelling under the tongue. On examination, swelling is seen below. Which of the following statement is best describe this condition? It is, when you talk about, is it a retention cyst? No, it's an extravasation cyst. It is wrong. It's an mucous extravasation of sublingual gland. Correct. It is not minor salivary. It is not mucous retention. तो है ही नहीं extravasation है. So retention तो वैसे ही निकाल दोगे. The extravasation बचेगा. Answer is going to be B for Bombay. It is going to be B for Bombay. It is for the sublingual glands. ठीक है? Easy. Good. Question number 48. A man presents to slow progressive swelling in the past 1.5 years. The swelling has variable consistency, appears as shown in the image below. What is diagnosed? It's a parotid swelling, the most common parotid swelling. Remember, it is pleomorphic adenoma. End of discussion. Pleomorphic adenoma is the most common parotid tumor. Okay. Question number 49. Which of the following is an indication for operative repair for thoracic aortic aneurysm? बेटा thoracic aortic aneurysm, the ear lifted हो तो sign हो गया ना parotid swelling का. Curtain sign positive होता है, you cannot move it above the zygomatic arch. Retromandibular groove fullness, ये सब है. ठीक है. Then they'll talk about parathyroidectomy के complication क्या है. एक आपका Frey syndrome मिल जाएगा. ठीक है. Gustatory sweating वाला. Facial nerve कैसे identify करोगे? Colles pointer, the tragal pointer. 1.1 to 1.5 centimeter medial and below the tip of the tragal cartilage is the root of your facial nerve or the trunk of the facial nerve. ये सारे पुराने questions हैं. Again, quick revision, no problem about it. ठीक है. Okay. For all your aortic aneurysms, ठीक है. Any single time you see a question of aortic aneurysm, you ask yourself a question whether the patient is symptomatic or asymptomatic. whether the patient is symptomatic or whether the patient is asymptomatic. If the patient is symptomatic, irrespective of whatever the size of the aneurysm, symptomatic aortic aneurysm, you should always repair. If it is asymptomatic, then we will look at the critical diameter. For asymptomatic patient, we will measure the critical diameter. Critical diameter is that diameter beyond which there is a risk for spontaneous rupture. So you have the ascending thoracic aortic aneurysm, descending thoracic aortic aneurysm, abdominal aortic aneurysm. Ascending thoracic aorta is 5.5 centimeters, descending thoracic aorta is 6 centimeters, abdominal aortic aneurysm is 5.5 centimeters. If a patient is of Marfan syndrome, if the patient is of Marfan syndrome, 1 centimeter less we have to see. In a patient of Marfan syndrome, we say abdominal aortic, that is ascending thoracic aorta is 4.5 centimeters, descending thoracic aorta will be of 5 centimeters, and abdominal aortic aneurysm will be of 4.5 centimeters. Okay. If it is asymptomatic, we will see the critical diameter. Okay. If the diameter of the sacc's diameter is more than the critical diameter, then repair. If the sacc's diameter is less than that of the critical diameter, then observation. Now, during observation, if there is increase in size of more than or equal to 5 millimeters in 6 months or more than or equal to 10 millimeters in 1 year, this is called as critical increase. You have to repair. You have to repair. ठीक है? Clear? So ये प्रोटोकॉल है एब्डोमिनल और यानी aortic aneurysm repair का. Now, asymptomatic ascending thoracic aorta diameter of 3 centimeter with bicuspid aortic valve. हाँ, कुछ तो फालतू का ऑप्शन दिया हुआ. ठीक है. Let's decode one after the other. This is not an indication. 3 centimeter तो कतई नहीं है. So strike this off. Asymptomatic ascending thoracic aorta. Ascending thoracic aorta का 5.5 centimeters है. 5 centimeters नहीं है तो ये भी गया. Descending thoracic aorta का it is 6 centimeters तो ये भी गया. When the diameter of the ascending aortic aneurysm increase more than 0.5 centimeters, यार actually तो सारे wrong है. 0.5 centimeters in 6 months है. अगर 6 months बोलूंगा, then the answer will become D for Delhi. ठीक है. Increase is not 0.5, just make small change कर लेना. ये 0.5 per 6 months होना चाहिए. 6 months ये 1 year गलत दिया हुआ है. So answer here is going to D for Delhi. Otherwise चारों के चारों गलत है. ठीक है. So this is in the context of aneurysmal repairs. Got it? Okay, how many questions? अच्छा, bonus questions भी दे रखे हैं मैंने. अरे यार, मुझे लगा खत्म हो जाएगा. कोई नहीं, bonus questions भी करा ही देते. So question number 50. Which among the following are the indications for shift of the patient to the burn center? देखो, whatever cannot be managed at home, then you have to take the patient for like burn center. Inhalational injuries, yes, patient requires respiratory. I mean, intubate करना पड़ेगा, घर पे नहीं कर पाओगे तो 1, yes, I have to take it. More than 5%, no. If it is more than 15 to 20%, तो 5% तो कतई नहीं है. 15 to 20% of total body surface area burned, then I'll admit. 5% I'll not admit. Electrical burns, yes, because there's a sequelae of that can occur. Post electrical burn, the patient can develop either cardiac components or can develop myoglobinuria. Yes, you have to get it aggressed. So again, electric burns. Lightning burns also, yes, they have a sequelae. Chemical burns also, they have sequelae, so I'll admit them. 1, 3, 4, 5. 1, 3, 4, 5. B for Bombay is correct. You are also correct. Good job. Question number 51, bonus question. क्या है bonus question? Patient with leg injury was treated with skin grafting as shown below. Which of the following statement is false regarding the type of skin grafting? Okay. The degree of the contraction depends upon the amount of dermis. Yes. है ना? So we say the amount of the dermis that you take is inversely proportional. ठीक है? To the graft contracture. जितना डर्मिस होगा उतना कॉन्ट्रैक्चर कम होगा. More dermis, less contracture. So this is correct. Healing with abnormal pigmentation is more common. Okay, high reliability of take is there. Okay, we'll look at the fourth option. Meshing graft improves the ultimate cosmetic. यार meshing से cosmetic improvement नहीं होता है. They increase the surface area. They increase the surface area and they have poor cosmetic outcome. छेद करोगे तो और गंदा दिखेगा ना यार, राइट? ये तो कोई रॉकेट साइंस हुआ ही नहीं. क्लियर है? क्लियर है ना? तो आंसर डी गलत है. चलो, क्वेश्चन नंबर 52. The image shown as a surgical technique used to release post finger burn contracture. The following statement is true regarding this image. ये क्या है? ये Z प्लास्टी है. इसको आप बोलते हो ये Z प्लास्टी. Z प्लास्टी आप क्यों करते हो? To increase the length of the wound contracture. कितने से इंक्रीज होगा? How much will be the increase in length? So you have 30 degrees, 45 degrees, 60 degrees and 90 degrees आप angles ले सकते हो. Increase in length by 25%, increase in length by 50%, increase in length by 75% and increase in length by 100% depending upon the angle of the Z-plasty. ठीक है? Z-plasty का angle क्या है? अगर मान लो कि ये आपका wound contracture है. Imagine that this is your wound contracture. Imagine that this is the wound contracture और ये contracture release कराना. ठीक है? This contracture you want to release. I will put the incision. I'll mark it as point A and point B. इनके बीच में incision डाल दिया. Then I'll mark it as point C here and point D here. ठीक है? So A to D एक incision करेंगे और B to C एक incision करेंगे. So this will be our line of incision. Now once you have incised it, all that I will do is I will hold point D and point से दोनों को stretch कर दूंगा तो length हो जाएगी. और ये depend करता है इसके angle पे. अगर ये एंगल 30 डिग्री से इंक्रीज इन लेंथ इज बाय 25%, अगर ये 45 डिग्रीज है तो 50% से इंक्रीज करेगा एंड सो एंड सो एंड सो. दिस इज योर जेड प्लास्टिक. ठीक है, अब स्टेटमेंट देख लेते हैं. Which of the following statement is true पूछ रहा है. It can also be used in surgical management of keloid scars and contractures. ठीक है. It orients the direction of central wound by 90 degrees. Nope. Triangular flaps created using 60 degrees can increase the length by 50%. नहीं, 75% है ना, तो ये भी गलत है. It's a type of a local advancement flap. इसको आप local advancement flap बोलोगे या फिर आप इसको एक transposition flap बोलोगे. What do you think is the right answer? What do you think is the right answer? It is a transposition flap, local advancement नहीं है. It can also be used in surgical management. देखो keloid में तो excision करेंगे यार, उसको थोड़ा keloids we usually avoid surgeries also, और वहाँ पे Z plasty नहीं होती है, keloid excision होता है. तो ये भी गलत है. Actually चारों गलत है. It reorients, option B एक बार फिर से रिव्यू कर लेते हैं. It reorients the direction of central wound by 90 degrees. You can use 90 degrees angle. तो अगर चारों में से देखना है, I think B is a better option. और वो B for Bombay is a better option. बाकी तीन तो absolutely गलत है. चलो, क्वेश्चन नंबर 53. ये तो स्पॉटर ही हो गया. इट इज योर एक्स्ट्रा ड्यूरल हैमरेज. EDH कैसे बताया? कॉन्केविटी बाय कॉन्वेक्स ओपेसिटी और ऑल्सो कॉल्ड एज लेंटिक्युलर ओपेसिटी. इट इज योर लेंटिकुलर ओपेसिटी. ठीक है. अच्छा, क्वेश्चन बोलता है 26-year-old batsman was rushed to ER after suffering a blow to the head with a cricket ball. The patient was unconscious on arrival. After some time, patient regained consciousness. Then he again started to deteriorate rapidly. Lucid interval भी positive है. A plain CT was done. What is the diagnosis? यार मतलब ऐसे तो मतलब अगर if you have done lectures with me, ये तो मतलब ऐसे 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 हवा में उड़ते हैं, ठीक है. So this is your extradural hematoma, not subdural, not subarachnoid, not intraparenchymal, ठीक है. So biconvex EDH. चलो. Question number 54. Okay, ultrasound diagnosis of pneumothorax depends upon which of the following sign. USG में क्या क्या है? Number one, there'll be absence of seashore sign, presence of barcode sign, and presence of stratosphere sign. Presence of stratosphere sign. ठीक है. So ये आपके pneumothorax में देखेंगे. Absence of sliding sign is correct. Presence of seashore sign नहीं, ये wrong है. Absence होना चाहिए. Absence of cometal artifact, absence of barcode, presence of barcode sign is correct. ठीक है. So 2 और 5 are absolutely correct. तो 2-5 का कॉम्बिनेशन कहाँ पे? 2-5 का कॉम्बिनेशन एक ही जगह पे, B for Bombay, right? Absence of cometal artifact is also arbitrary correct, but these are the important ones to be remembered. So answer here is going to be B for Bombay. Is going to be B for Bombay. Question number 55. देखो anterior mediastinal mass है, ठीक है. ये anterior mediastinum है, वहां पे mass है, ठीक है. Okay. 35-year-old patient with double vision that worsens after watching television, ठीक है. He also has drooping of the eyelid that gets better after a nap. अरे यार myasthenia gravis के symptoms हैं, तो myasthenia gravis किस में देखोगे? थाइमोमा में देखोगे. Serology is positive for anti-acetylcholine receptor antibody. CT scan of the chest is given. Which of the following is a false statement regarding this? So basically ये जो condition है ये थाइमोमा है. It is the most common tumor of anterior mediastinum, correct. Masoka classification is used for staging. Now, when you talk about Masoka classification for staging is also correct. No, thymoma Masoka is tumor size is relevant. No, tumor size नहीं है, capsular breach है, ठीक है. Tumor size has no role. It is about the capsular breach that matters. It is the capsular breach that matters, ठीक है. Surgery can be performed through a mediastinal sternal approach. Yes, you can do it. We do laterally also. See, thymectomy I have done using robotic right approach, left approach. We have done with VATS also. We have done medicinostomy also. So all the approaches are possible. So answer here is going to be C for Calcutta. Tumor size नहीं determine करता है, capsular breach determine करता है. And the last question for today, it is question number 56. Wrongly ने 201 लिख दिया. देखो ये जो लास्ट में लिखा हुआ ना, गलती से ने 201 लिख दिया, ठीक है. But I'm telling you ये गलती नहीं है. It is the universe telling you that you are going to score 201 above, ठीक है. So stay focused, stay hungry and work as much hard as you can till the exam. उसके बाद फिर GCS 8/15 करके सो जाना, ठीक है. कोई दिक्कत नहीं है, लेकिन we'll fight until the exam. So this is the universe telling you that you are going to score more than 200. चलो. A 71-year-old man with acute STMI, okay, with coronary stenting was performed. On the follow-up visit, he reports pain over his toes and discoloration of both the feet as shown in the image. His creatinine was also elevated. What is the most probable diagnosis? क्या है ये? It is embolism. It is an emboli. It is not a Sharp syndrome. देखो all these fancy words, no, I don't want to go across it. ठीक है, मुझे पता है it's an emboli post your stenting is there. So answer is going to be D for Delhi. Aortic dissection में pain होगा, diaphoresis होगा, MI-like features होंगे, all that होगा. Antiphospholipid antibody syndrome आप मेडिसिन वाले से पूछे, मेरे को तो सुना भी नहीं है, तो ये होगा नहीं यहाँ पे. Sharp syndrome is also in that context. So answer is going to be atheroembolism. ठीक है. So most common source of emboli is going to be heart followed by aneurysm. So that is one of the reason that you can see emboli are going to be present across here. ठीक है. चलो. So that's it for today's TND. We have done approximately 56 questions. We have covered the entire topic spectrum that is usually asked. ये सारे जो questions हैं, ठीक है, all these questions are picked based upon the recent trends of NEET PG, INI as well as FMGE exam. ठीक है. So stay focused, stay hungry. No matter who says what, in the last 2 weeks that we have, give everything you have. Don't hold back. ठीक है. Give 18 hours, 19 hours, 20 hours, doesn't matter. Make sure you revise. Start doing questions. Make sure you're doing 200 questions per day at an average. Start revising your subjects. ये कभी भी मैटर नहीं करता कितना आपने पढ़ा है, ये मैटर करता है कितना आपने रिटेन किया है. रिटेनमेंट की पावर सिर्फ और सिर्फ आपके रिविजन से है, ठीक है. सो इफ यू आर नॉट रिवाइजिंग, देयर इज नो पॉइंट गोइंग टू द एग्जाम. बेटा द गोल्डन रूल इज 4 रिविजन करने हैं, 200 क्वेश्चंस करने हैं. एंड मेक श्योर यू स्टिक टू योर मटेरियल. डू नॉट थिंक इधर उधर. कोई ऐसा जो आपका दोस्त है ना, अ गाय हु कम्स टू यू एंड सेज कि यार ये वाला क्वेश्चन पढ़ा, वो वाला क्वेश्चन पढ़ा, ये टॉपिक पढ़ा, वो टॉपिक पढ़ा, वो अगर आपने नहीं देखा है, नहीं सुना, उसको एक बात बोल देना कि ये जो तो पूछा ये तो कतई नहीं आएगा एग्जाम में, बाकी कुछ भी हो जाए, ठीक है. कीप दैट कॉन्फिडेंस इन माइंड. Have a self belief. This is the time where you will doubt yourself a lot. You will have a lot of questions. You will have anxiety. You will feel as if the world around you is trembling. This is normal, or this is what is supposed to happen. अगर सब कुछ ठीक लग रहा है तो सब कुछ गलत है, और सब कुछ गलत लग रहा है तो सब कुछ ठीक है. यही रिवर्स एनालॉजी है एग्जाम तक. बट लगे रहना, कुछ भी हो जाए, बीमार हो, खांसी है, जुकाम है, नींद नहीं आ रही, खाना नहीं खाया, ठीक है, इधर चले गए उधर चले गए, कोई भी, डोंट वरी अबाउट इट. The only advice that I would like to give you is put your head down and work. That's it. एग्जाम के बाद मिलते हैं. 201 आपका लगा हुआ था, उसके ऊपर ही मिलेगा, ठीक है. Every single person, when you score more than 200, do text me, do let me know that your performance was good. I would like to celebrate with you. Until then, thank you, goodbye, take care, have fun, and we'll meet for marathon series also. There will be also a quick revision for your general surgery. All right. एडवाइस यही है, पुट योर हेड डाउन एंड वर्क. उसके अलावा कुछ नहीं है. ठीक है, चलो, थैंक यू सो मच. थैंक यू फॉर स्टेइंग अप. I mean, we had a very good live audience also. A free session and a lot of kids coming up shows that you have faith in our system. Thank you so much for that. And if you have any questions, I'll be uploading the notes in the Telegram group, also in our PW group also. So make sure you just revise them. And if you have any questions, do reach out. Thank you so much.